targets are rapidly dividing cells, and our bone marrow is a source of rapidly dividing cells. Every day, our bone marrow has to put out new cells because our white cells have a lifespan of about 7 to 10 days, our platelets about 7 to 10 days. So if you don't put out platelets and white cells for one day, you are going to see a drop in the population. So what you're seeing is that during the incubation period, the virus tries to get in. Now, once the cell in the bone marrow, that means the precursor cells, have been infected by the virus, when the immune system is stimulated, they are destined for destruction. All right. So if we don't have a mechanism of protecting the bone marrow cells from infection, then all your bone marrow cells will be wiped out during the immune phase, right? So what the body does, the cells do, is that they live in a colony. They are like, villagers in houses in the village. When one cell is infected, that cell puts out chemicals, chemokines, cytokines, to inform all the other cells, please downregulate. Don't do any more differentiation. So there is a transient bone marrow arrest. You see? So there is no more differentiation, no new cells coming up, and then that's what you see. All right? So what we see in the peripheral blood is actually changes that are lagging behind the bone marrow changes. All right, so no more white cells coming out. So by day 2, the population of white cells will come down. So all these are all old white cells that are living out their lifespan. So the white cells get down to a very low level at the time of the critical phase. And when the antibodies start to appear and clear up the infected cells, then the bone marrow starts to produce again. And you see the recovery of white cells towards the critical phase. All right. So I hope you understand why the changes are like that, so dynamic. All right. Now, similarly, the platelets have the same picture. All right. The megakaryocytes in the bone marrow they're going into arrest. They have been told, they have been informed, don't but anymore platelets. So the population in the peripheral blood will come down. Will come down slowly, gradually over the days. But then at defervescence, there is a very sudden drop. Okay, now this is not related to the bone marrow. This is bone marrow changes. Okay, the arrest of the megakaryocytes. These are a peripheral activation of the endothelial cells as a result of the antigen antibodies now interacting. So this is a separate mechanism. So even though at this point, the bone marrow is actively putting out platelets now, reactivated because the virus has been cleared, the platelets are being consumed peripherally. So they remain really, really low for much longer than the white cells. And then towards the end of the critical phase, towards end, they start to come up. All right, so that is a very dynamic picture. Now, the story with the red cells are slightly different because red cells have a longer lifespan. Red cell, the lifespan is 120 days compared to white cells and platelets, which has about 10 to 14 days, right? So if you don't produce for 1 week, their population will still be stable because they have a longer lifespan. But you can see that as the patient transits from the febrile to the critical phase, there is a sharp increase in the hematocrit, and it reaches very high, and then it comes down. Okay. Now, this sharp increase is because of plasma leakage, and this decrease, this is where things become very complicated. Yeah. So this decrease is either due to, it's not natural. It could be natural, but it is due to either our fluids, giving the fluids to the patient and it comes down, all right? Or it could be bleeding, all right? Now you have two different spectrum now. Of course, if you're giving fluids and the patient's, the hematocrit comes down, you would expect to see a very stable patient. But if this patient is bleeding, his hematocrit is still high above the baseline, which is here, he is really, really shocked, all right? And then if they go into the recovery, if they recover, then there is a dip here because of the reabsorption, and then the kidneys will get rid of your fluid, and then things come back to normal by day 10 of the illness, all right? So very dynamic, and you've got to try and kind of understand how things, so now, as a clinician in the front line, I think we need to also focus not just on the full blood count, but really the patient. Okay, all these are all the diseases, but the patient, when it comes to the patient, there are only two things that are actually important. What is it? Urine output, oral intake, and urine output. All right, so dehydration sets in very, very early. High fever, nausea, whether they have diarrhea, vomiting, that adds to it. Okay, so dehydration sets in from day one, and then it accumulates. That effect is cumulative. So by time, you can imagine by day 3, day 4 of illness, they are quite dehydrated already. And if they go into the plasma leakage, they're going to crash very rapidly. Now, this happens with children, okay? Usually within about the onset of plasma leakage, within 6 hours, the children have already gone into shock. All right, that is with children. Now, with adults, might be a little bit longer because the capillary permeability is not so severe in adults, but it makes it worse because it means that they won't present so early and more subtle, right? Now, if together with the dehydration and now the capillary permeability, they will very rapidly go into shock, hypovolemic shock, and we don't recognize this, then they start to bleed. So you can imagine now the disease becomes very life-threatening. If they survive all this, like I said, this is very predictable. Now at this critical phase is actually quite predictable. 48 hours and they slowly get out of that shock and they go into the recovery. There are other obstacles. Most of it is related to how we manage our fluid. Okay, it can develop fluid overload. Organ impairment usually related to the shock, but sometimes it extends well into the critical period because of activation of the other parts of the immune system, like the macrophages. So now we'll talk about the febrile phase because that's what you see that's what brings them to your clinic. Usually lasts 2 to 7 days, but minimum we said is about 72 hours. The temperature is typically very high, but in older patients, you got to be a bit careful. They may not even have the fever. That is very, very subtle. However much antipyretics you give, it will only modify it. It will not bring it down. Other symptoms that they may complain about are myalgia, headache, retroorbital pain, body ache, rash. And remember, they won't tell you this. You have to probe. They are anorexic. Diarrhea, they may tell you. They will not tell you. You have to probe. Lethargy. Okay, certain things that you have to probe. All right, so we'll go through that part a little bit later. Now, if you do recognize this phase is what we call the undifferentiated febrile phase, meaning that you can't tell whether this is influenza, COVID, measles, you don't know. Unless, and even if you do a full blood count, it's going to be normal. Remember the profile? It's going to be normal. The CBC is going to normal. The platelets are going to look normal. So you may think that, oh, your patient, you tell your patient, oh, it's not likely to be dengue. Now, this is quite dangerous. So nowadays, we have the NS1, the diagnostics can tell us. The chances of it being positive is actually very good during the febrile phase. The first 5 days is actually very good. Yeah, but it's of course never 100%. Nothing is 100%. There are always false negatives, but which Dr. Sharifa will talk about. Now, the quality of life of the patient has already changed. The mothers will tell you, my child is different, behaving very, differently. And for adults, they might clock into work, but they cannot concentrate on their work. So seemingly they are walking, they're clocking into work, but they are actually lying down there and sleeping away. All right. In children, nausea and vomiting may be prominent symptoms. All right. Now, so that's febrile phase and transitioning from febrile to the critical phase, usually after the 72 hours, so on day 4 to day 7 of illness, and could be earlier, and the temperature comes down. It's not like afebrile yet, but it could be not as like 39 and 40, but it's still 38, and they start to develop warning signs. Okay, these are patients who are or either already in shock or at risk of developing shock. So you have to be familiar with the warning signs. It's severe persistent abdominal pain. All right, it's persistent vomiting, mucosal bleed might happen, lethargy. By the time they become restless, it's another stage beyond. The liver may be enlarged at this point. If you have an ultrasound, you might find fluid accumulation. If they haven't received IV fluid, they are dehydrated, you may not see it, even with an ultrasound. But if they have been receiving IV fluids, you could detect that fluid accumulation. Other laboratory signs, then you start to see the white cells getting less than 4,000, all right? Platelets are rapidly dropping, and there could be a rise in hematocrit. So you can see that if you're seeing the patients, which you are doing in the febrile phase, it's difficult to predict the cause of the illness. Okay, the febrile viremic phase is 3 to 5 days, and then once they transit, it is the immune phase. Not so high fever, maybe afebrile, and the immune system is now interplaying with the virus. So it is during the immune phase, day 3, day 4 onwards, that the severity of the disease is observed. Okay, so they may go into the afebrile phase with not they get better, or they may develop warning signs, or they very rapidly deteriorate to severe dengue. So those with non-severe dengue will definitely recover. Those with warning signs may recover, or they can go on to develop severe dengue, and that's when death is quite. There's a risk of death at this point for the severe dengue patients. So now we'll talk about the warning signs. Okay, a little bit about the warning signs, the abdominal pain. So we mentioned that it is a very severe abdominal pain. Okay, what is the meaning of severe? So quite often it is the chief complaint. They'll come in, they have the chief complaint. If they're seeing you for the first time, you might think that this is surgical abdomen, right? Because they are not going to tell you that, oh, yesterday I have fever, today I don't have fever, but I have abdominal pain. They are not going to tell you this story unless you probe, right? So it is like the chief complaint, and it looks like a surgical abdomen. So what makes what does it signify? So we have to remember the context, all right? So if you were asked a little bit, what were you like yesterday? Oh, semalam the demam sudah habis. Sudah settle already, tak ada masalah. Then today, abdominal pain. To them, it's two different diseases. They are not able to join the dots. But if you have gone through this course, I hope you'll be able to join the dots, that the fever of yesterday and the abdominal pain of today are ada kaitan. Now, what is meant by significant? What causes it? It is the increased vascular permeability, there is shock coming on, there is splanchnic vasoconstriction, and this usually occurs with a defervescence. Right? Now, the most common diagnosis pitfall is that some doctors will say, tentu lah, you haven't eaten for so many days, it's gastritis lah. Then if you have an ultrasound and then you shine around and you see, oh, gallbladder sudah enlarged, oh, you have a gallbladder problem. Quite often we end up with this kind of diagnosis, all right? So that's the severe abdominal pain. Now, what about the persistent vomiting? So persistent vomiting, WHO has defined it as 3 times or more, all right? But I think we should not be, what if the patient vomit 2 times? Kira kah? Once only? What do you think when you put that child patient? Yeah, so we cannot be so black and white in the way we approach patients. Also, this kind of history, you will get it when you can see that these guidelines are actually done by pediatricians, Pediatrics patients have vomiting a lot, right? It is very impressive with children. Vomiting is definitely a feature. And it took me a while to understand why vomiting is such a feature with children until I saw a patient where the student told me that this child is admitted because he vomited 11 times in the morning. 11 times. Isn't that impressive? 11 times. So, you know, if you get that kind of history, you'll sure run down to see the parents, right? So you run down to see the parents, and then the first thing you ask is, what happened this morning? So the parents will tell you the story. You know, say that, oh, pagi ini dia bangun, dia tak nak minum. Dia tak minum, you think the mother will say, oh, you tak nak minum, it's okay, no need to minum. No mother will ever do that. The mother will force the milk down the child. Okay? So after forcing the milk down the child, what happens? Vomit lah. So vomit number one. Then if you're the mother, you think you're going to just leave it? No. You're going to make another bottle of milk, and then the child doesn't want it, you force it down again. So vomit number two. So the mother will do this several times until 11 times give up. I take you to the hospital. Okay? So you will get this kind of history with children because there is a mother to do that, forcing down. But nowadays, we are not seeing children with dengue, we are seeing adult patients with dengue. You think there's a mother to force it down, there's a wife to force it down, or a husband to force down a drink? No, they're just going to, oh, you tak nak drink, it's okay, you drink. All right? Now, when you ask the patients, you know, are you able to drink? You ask for vomiting, tak ada muntah. So if you take it as that at face value, then you miss the picture. You have to turn the question around. Are you able to drink? Oh, doktor, tak boleh. Why? Oh, kalau minum tentu muntah. Tak minum, tak muntah. So where do you put the patient? Tak minum, tak muntah. Got warning signs or not? So we really need to put the context in. I say that we cannot be so focused, tunneling into the persistent vomiting. We have to have a broader view, a more peripheral vision. Now, what does this mean? It's a very important sign of plasma leak. All right? So, lethargy. The lethargy that is more than usual. Okay? It's like we mentioned, they're viremic, they're not eating, so they are lethargy. Here, this lethargy is very different. They are not moving. They're just on the bed, sleeping most of the time. They are uninterested in food, television, handphone, and iPhone. They're too weak to walk to the toilet. Okay, that is, now lethargy precedes that restlessness. Okay, by the time they're restless, and their brain is already hypoperfused. Mucosal bleeding, of course, is a very visible sign. They will come. Fluid accumulation is something that we rarely see at the front line unless you have an ultrasound. But if you are giving IV fluid, that could become a prominent feature. All right? Now, other features around about this time that as a patient is transitioning into the critical phase is the leukopenia. And the leukopenia usually, in those days, that is the only thing that we had. When the platelets, when the white cells start dropping, we'll think that, okay, tomorrow you are going to drop your platelets already. It doesn't predict the plasma leak, but it's a good indicator that the patient could have dengue. Okay? A rapid rise in platelets and a rapid decrease in platelets and a rising hematocrit trend. Now, this is the only disease that you see one goes down, the other one goes up. All right? Yeah. So it occurs in dengue. All right? And this occurs shortly before or at the time of effervescence. It precedes the changes in the blood pressure and it indicates vascular permeability. But if the patients, nowadays we have NS1 positive patients are admitted for IV drip at the time of the febrile phase, you may not see this. You may not see the rising hematocrit, okay? But the patient is filling up. His pleural space, his ascites. So be very careful how we interpret those numbers, is how it interfaces with our management. So I'd just like to kind of illustrate to you what it is like. So this is a 32-year-old man who have no comorbid conditions. His fever onset was on the 9th of July. And then on the 10th of July, he went to see the GP. His regular GP, he's at temperature of 40 degrees, blood pressure was 140/88, and the heart rate was 110. The GP said, oh, you have a viral fever. And then, but nonetheless, gave him antibiotics and then prescribed Voltaren, 1 tablet twice a day. So on the 3rd day of fever, he was at home, and then he represented to the GP, same GP, on the day 4, and his chief complaint at that time was vomiting, reduced appetite, and abdominal pain. Right? And his blood pressure was 100/60, and the GP saw the patient. It's the same GP at this point, yeah? And the GP said that you don't look well. The patient said, no, I'm okay. My fever is down. Just give me medicine for my abdominal pain, right? But the GP said, I better run a test on you. So did a blood investigation at 12 o'clock. That came back at 3 p.m. And the NS1 was positive, IgG, IgM negative, hemoglobin 18 grams, platelets 11,000. All right, so it is quite rapid. So the GP wrote a letter, you better go to the hospital. Actually, the patient didn't want to go. He didn't think there was anything wrong with him because the fever was down, but the wife was with him. So the wife said, no, you go to the hospital. I'll take you to the hospital. So they ended up in the hospital at 4 p.m. So he walked into the hospital and he was triaged to the green zone. Fever no more already, no fever zone, so green zone. All right. So in this hospital, he had a second triage, and his temperature was 37.5. And because temperature is normal, green zone. You know, green zone means what? Tunggu lah, kena tunggu, right? At 6:30, he fed up already. He said, I'm going home. The wife said, cannot, you cannot go home. I'll take you to another hospital. So he went to another hospital, and this time he was seen by the MO in the second hospital. His heart rate was 100. His temperature is now 36 degrees Celsius, and his blood pressure is 100/70. And the ED physician attended to him, found him lethargic, but he was still talking. He was cold, dusky, thready pulses, kept refill more than 7 seconds, and the diagnosis and dengue shock. Okay, so it took how many hours? He's been to 2 hospitals, and by 8 p.m., he was diagnosed as dengue shock. They couldn't put in a line. They struggled, but they resuscitated him, admitted him to the ICU, and on the 14th of July, he passed away. And this is despite massive transfusion. Massive bleeding, massive transfusion, he passed away. So within a span of less than 10 days, healthy young person is gone. Okay, so it can be very rapid, aggressively rapid towards when they get into the critical phase, yeah? Now, so what are the pitfalls when they can't get into that shock phase, okay? So this is you have to think about as a very continuum. It's not staged. It is going very fast, and time is of essence. So in the beginning of the shock, as they get into the plasma leakage, the shock is, the body will try and compensate for that. So the blood pressure will still be normal, and then is what we call the compensated shock phase, and then they will go into a decompensation when they could no longer. Ongoing leakage, and then they will go into hypotension. So when they look stable, and then they develop warning signs, and then for several hours they can still compensate, and then they develop shock. Okay, the shock is still, blood pressure is still holding. Okay, so when you measure it, it's still normal, and then after several hours, some more of delay, then they develop hypotension. Once they develop hypotension, it won't be hours. It will be minutes before a cardiac arrest. All right, so it is very challenging to manage patients at this point, okay? But if you manage them in the early shock phase, the outcome is very good. A delayed treatment leads to severe bleeding and organ impairment, very complicated, and can be quite often irreversible shock with a very poor outcome. So question is, why is it easy to miss dengue shock? Okay, I have missed a dengue shock before, okay, in our younger days. So it's not difficult. Why? Because they are talking. They are walking and they are talking. All right, so they look normal. Okay, they look normal. When you're looking at them, You're walking, they're talking, they're giving you a history. They can even sign a consent form if they're in a study. Okay, so which means that it is just looking and talking to them is not enough. They are talking, they're lucid, right? So it means that we have to examine them very carefully before to detect to recognize the shock stage before the stage of collapse, right? So we'll go into that part. Pardon me? Yes, a lot of patients do not get into the hospital. They collapse at home. You're right. You see, because they look normal. They are having breakfast with their family and then suddenly they collapsed. It's not, to us, it is suddenly, but the body is compensating. It's just that we need to examine them to detect those signs, physical signs, which we'll talk about in the clinical evaluation. Pardon me? The fever phase is over. The patient is now afebrile now. They are past that febrile phase. I think you kind of follow me. We are now in the febrile phase of the illness, the critical phase of the illness, where the fever is no longer a major feature. We will then summarize a little bit later. So when we do a history taking, it's very important to probe. The date of onset of illness is very important because it will set you to whether you are still within the 72 hours of febrile illness. It will help you determine which phase of illness the patient might be in. There is no accuracy, but at least it gives you an estimate of how close you are now to the critical phase. Symptoms and severity, usually the patients will tell you that they have headache and all that. Yeah, so that is important to recognize. But I think this is very important. This is where you need to probe, okay? You have to ask the 3 golden questions. They are not going to tell you this. You have to ask them, how much are you drinking? What are you drinking? All right? What is your urine? When was the last time you passed urine? What was the color? So these are the things that will tell us how the patient is coping with that febrile illness. Okay, what are they doing? Are they playing? Are they working? Or are they just lying in bed? So that will give you an idea of how they are coping with the illness. Then the other fluid losses, like diarrhea and vomiting, will just add on to your severity, fluid losses, and the warning signs. We know the severe abdominal pain, the vomiting, but remember the context of this, right? If you are not getting vomiting and you didn't probe the fluid, you might just miss it altogether. Now, other relevant histories, what is happening in your neighborhood, well, the whole country is endemic now, medications that they are taking, comorbid conditions, these are risk factors. Infants, first year of life is a risk factor for severe dengue. The pregnancies, obesity, diabetes, hypertension, hemolytic anemia. I think this morning somebody has covered that these are risk factors for more severe dengue. 9 and 10 are more of a differential diagnosis. Sometimes you may have to think about others like lactotyphus, malaria, or HIV seroconversion illnesses. Right? Now, when we examine the patients, the mental state, hydration state, and I will touch on the hemodynamic state a little bit later, and bleeding manifestations, tenderness in the abdomen, liver is enlarged or not, fluid accumulation, and rash, acidotic breathing. And if you are working in you don't have any other tests, a tourniquet test might be useful. Okay, if you get a positive tourniquet test, then the chances of the patient being dengue, although it's non-specific or nor sensitive, it may give you an inkling of the platelet count. Now, when we do our hemodynamic assessment, it's basically balancing out the peripheral circulation versus the central circulation. Peripheral circulation is represented by skin perfusion, and the central circulation by the organs, and we are talking about really cardiac output and respiratory compensations. So basically, when we are looking at a patient from the circulatory point of view, we're talking about the macro circulation versus the micro circulation, which is the organ perfusion. So these are the 9 parameters that we look at. Okay, so there are 9: conscious level, cap refill time, extremities, color and temperature, peripheral pulse, volume, heart rate, pulse pressure, blood pressure, and respiratory rate and urine output. Okay, so the peripheral perfusion is represented by these 3. I will cluster them. These are the cardiac output parameters, conscious level. The conscious level is a function of the organ perfusion. Urine output is a function of the kidney perfusion, and the respiratory rate is a function of the acidosis. Okay. Now, in a stable circulation, they are all normal. So we'll go through quickly. Now, this is what happens in dengue shock situation. This is the x-axis is time. These are the parameters. In this case, we are measuring the heart rate and the blood pressure. So you can see that with increasing plasma leakage, it is the diastolic pressure that increases. All right, the systolic pressure remains stable despite the plasma leakage and the decrease in intravascular volume. Okay, so this narrows the pulse and makes the pulse weaker. Right, that is so. A rising diastolic pressure with a narrowing pulse and a weak pulse and a tachycardia. So at this time, the peripheral perfusion is already compromised. The extremities are cool, pale, prolonged capillary refill time. Patient will be breathing faster, but his conscious level is still okay. If you asked about his urine, it will be less, slightly darker in color. All right, so these are quite useful features to ask about. So in a compensated shock phase, the peripheral perfusion is already reduced, the cardiac output is already decreased, but the systolic pressure is still compensated. It's still maintained by the vascular constriction, peripheral vascular constriction, and the tachycardia. The pulse pressure narrows. There may be postural hypotension, and as long as the systolic pressure is maintained, the brain is still perfused, the patient is still walking and talking to you. So the urine output is already reduced. If you ask about it, you might be able to detect it. If you didn't ask, then it's lost. Okay, tissue acidosis is beginning to form. The breathing is faster now. All right, so this is in a compensated shock phase where the systolic pressure is still maintained. So in a compensated shock phase, everything has changed except the systolic blood pressure. And as long as the systolic blood pressure is maintained, the conscious level is still, the brain is still perfused. Now, if this situation continues, then the patient continues leaking and hypotension will set in. And when it does, it is rapid. Okay, very rapid, very sudden, very increased tachycardia, absent pulses, systolic diastolic pressure disappears, and by this time the patient is really cold, mottled, capillary refill time is very prolonged, the breathing is now Kussmaul's breathing, and conscious level is no longer normal. All right, urine output also nothing. So in a hypo, what is the key change is that mental state. The patient is now very restless, extremely lethargic, maybe very confused. They may even have seizures, or they are agitated. And if you leave them alone, they're going to drowsy, and you go and kacau them, they will, don't touch me, that kind of things. All right. So in infants and young children, a little bit can be a bit different, but because there is a parent to notice it, that a child looking at me but not focusing. Parents feel that something is wrong. You better listen to the parents. Okay, something is wrong and examine more carefully. Right? But there are some children and young adults who continue to have clear mental state. Like I always say that the most dramatic one is the one person riding the motorcycle from the village to the hospital. And then you will be thinking, oh, you know, when he reaches the ED, he just drops his bike and then he marches in and then he lies down. If you just see him like that, you think that, why is he behaving like that? It's only when you touch him, then you realize that actually he's in shock. Okay? So sometimes if you just see without touching, it can be very misleading. Now this is imminent, total cardiorespiratory collapse. Right now, so this is the end phase. You don't want to see patients like this if in your practice. So now, how do we then, to avoid this phase, is to go for the earliest sign. Remember 9 parameters, which would be the earliest you would see, changes that you would see of these 9 parameters that we talked about. It's the urine output, okay? It's very important to understand the role of the kidneys in enabling animals to transit from aquatic environment to living on land, okay? And it's because the kidneys are bioengineered through millions of years of evolution to enable animals to concentrate their urine, their preserve water. All right, so that is very, very important. So monitoring your urine output, your kidneys will regulate your intravascular volume for you very accurately. Right, so even if you don't drink, you're not in shock. Your kidneys have already done it. The counter current mechanism will conserve urine for you. Okay, and in the severe shock state, there's no more urine. Okay, so what is considered an adequate urine output in the outpatient setting is that your patient drinks enough to pass enough urine, 4 to 6 times a day. Okay, and when they're in shock, they may not pass urine, but usually when we are resuscitating them, we will put in a catheter. Now, the pitfall is this, okay? If they have hyperglycemia, they do not know that they have diabetes, then they will continue to pass urine, even when they are in shock. All right, so this is very dangerous, okay? The glycosuria will just worsen the shock. So you can't take things at place value. Hyperglycemia will undermine the function of the kidney, right? So this is, there are some charts, what are called the urine color charts. This is the Armstrong, this is the Wardener. They will tell you, as a patient gets more concentrated, not only the volume decreases, the color changes. And if you rehydrate them, the volume increases, the color also changes. So I think this is, in our ward situation, this is in a place where you don't have any other tests. This is the thing to use, right? And we have, I personally have used it in very low resource setting. But you don't have anything else. Okay, the patient has got kidneys. Let's use the kidneys to help us manage the patient's fluid. All right, so in a hypotensive shock state, everything, all the organs have already shut down. And so one of the earliest ways to detect shock and fastest ways to detect shock is to hold the patient's hand, okay? So we called it a CCTVR, and it's almost magic because you can immediately feel the patient in shock, all right? Less than 30 seconds, you can already know, okay? When we hold the patient's hand, it's important to not just hold it, look at the color, do your capillary refill, feel the temperature, check the pulse volume, and the pulse rate. All right, so it's very important to do all 5. You can't do like 3 out of 5. You have to do all of them because it will give you the complete picture of what's going on in the system. So by holding the patient's hand, you already can feel about how many, you already got a peripheral perfusion and part of the cardiac output, all right? So this is how it would look like in a shock patient. Yeah? You already depressed, you do a capillary refill, you should fill up within 2 seconds, but 6 seconds later, the foot is still pale, all right? So this is very delayed capillary refill time, okay? So dengue is very, very dynamic. The phases and the clinical issues, the viremic phase, the febrile phase, and then we go into the immunological phase where the inflammatory process is. And that is from the 3rd day onwards. So when they come in, these are the clinical problems. the high fever, the nausea in the febrile phase, the dehydration, electrolyte imbalance, and they haven't been eating, okay? So there will be acute starvation, ketosis, and when they get into after day 4, critical phase, they face further problems: hypovolemia, plasma leakage, severe bleeding, dehydration, and if you have been giving all your paracetamol, NSAIDs, then the patient is faced with all these added problems: paracetamol toxicity and NSAID toxicity. So previously, when we didn't have the NS1, we focused our care on here, because this is when the disease is very differentiated. Okay, in a febrile phase, it's fairly undifferentiated. But nowadays, but you must remember, when they come in, they present at this point, it is not just plasma leakage. All the problems that we didn't resolve during the febrile phase is going to come in and complicate the picture. All right, so they are not only just having plasma leakage and bleeding, but they're having dehydration, organ impairment, toxicities, and all that. All right, so now we have NS1 positive patient. We hope that you can be more proactive in our management during the febrile phase, to prevent them when they get into the critical phase. They might have the plasma leakage, hopefully not a severe bleeding, definitely, hopefully not any more severely dehydrated and organ impairment and the toxicity from the drugs. All right, so this is, I think, my last slide. All right.
Thank you very much, Lucy. We are running out of time, but then there are a few questions here that I think maybe needs to be answered, because they're quite important. One of them is, I've been going through all the questions. Okay. Why do some patients still progress to severe dengue and die despite early diagnosis, early admission, appropriate treatment? How do you overcome this?
Okay, very interesting question. We have seen patients like these before. They are admitted early, and sometimes when we admit them patients early, we put them an IV drip early, hoping to preempt what happens later. So sometimes it complicates the whole. I think that is one of the things that we have seen in patients who come in, because nowadays with NS1 positive, we all thinking, it's dengue. So we admit them early for an IV drip. Okay? So we think that we can preempt. Sometimes that will add to the problem. Okay, so we will go through the management in the febrile phase later on by Dr. Ong. So hopefully we are not so like kiasu, like give the fluid early so that we can prevent the shock. All right, so sometimes we add to the problems. Yeah, okay.
So is it possible for dengue patient to go into shock on day 1 of illness?
Okay. Not likely. And I always say that what we think sometimes is day 1 may not be day 1, but I always say that look at your full blood count. Your full blood count will tell you whether this platelet count, is it a day 1 platelet count, or because what will not change. The history may be not reliable, but what will not change is your full blood count. The changes are that in the bone marrow, and what you see in the peripheral blood picture will tell you whether this is day 1 or not. If your platelets are 200, that can be day 1. If your platelets are 11,000, you are not day 1. You're day 4 or 5 already. All right, so your platelets are actually quite useful. Not for you to treat the platelets, but to kind of like give you a landmark, okay, of where you are.
Okay, one last question. This is about without the hematocrit. Right? In a patient who has high hemoglobin and hematocrit, like smoker or patient who is having anemia and low hematocrit, with no baseline FBC to compare, besides assessing the patient clinically, how do we interpret this type of FBC in dengue without a baseline hematocrit?
Yeah, without the baseline, and most of the time we don't have a baseline. So we operate without a baseline. Number one, you have a, this is going back to general lesson already lah. Okay, sometimes we look at the MCV, MCH, and then we agak. You know, if your MCH is normal, MCV is normal, probably your hemoglobin is like the population hemoglobin. But if you have a MCV that is very small, you know, like 20, and your MCH is like 60, or you definitely have some form of anemia there. All right, which means that your baseline hematocrit is not going to be normal, it's a low. Like if a patient has got a chronic kidney disease, yeah, and if they're not on erythropoietin, then their baseline is going to be low. So your knowledge of general medicine is very important for that. Guessing what your baseline is when you see the patient on day 4, day 5 is no longer the baseline. But your red cells will not change so fast. Like I said, your red cells last 120 days. They are not going to change so fast. So that gives you a very steady picture of what your baseline, you can guess lah, the baseline hematocrit.
Okay.
Faham?
All right, we don't have much time, but I'm going to take this one. This one is important question, last one. I think this very quick answer. What, don't change it lah.
Yeah. Okay, I
use
saw
of
the
platelets,
platelet
platelet,
replacement.
yeah.
Yeah. So like I mentioned earlier, your platelets count during that time may be very low, and it's low not because the bone marrow is not producing. It is being consumed at the peripheral level, and it's activated. The platelets are activated, so they are cleared by the liver and the spleen, and therefore the half-life of the platelets are very much shortened by 50%. All right, so when you so it's not the bone marrow is not producing, it's just that at the peripheral level there is. We have also got evidence that actually the bone marrow is actively producing the platelets. It's just that at the peripheral level it's been consumed faster than it can be produced. Yeah.
So there's no need to transfuse most of the time, right?
Yeah.
I think that's a good lesson to convey. Thanks a lot, Lucy. I know we have a lot of more questions here, but thank you. We have to move on, otherwise most of you cannot wake up for the game tomorrow. The next speaker is Associate Professor Sharifah Faridah Said Omar. She's a consultant infectious disease physician from UMMC, and she's going to be talking on diagnosis and case classification of dengue. Sharifah?
Thank you, Doctor. Okay, so you can change here, is it? So, mine? Sorry. Okay, thank you. Assalamualaikum and very good afternoon. First and foremost, thank you for inviting me to be part of this very important workshop on dengue management mainly for primary care physicians. So my topic this afternoon is on diagnosis and case classification. So we heard from Prof. Lucy about, the clinical cause of dengue and also how to assess a patient that you suspect to have dengue. So using diagnostic and also case classification will then further help you to better manage your patients. So these are the objectives of the talk this afternoon. So in terms of laboratory tests, when we want to test for dengue, to diagnose dengue, there's a spectrum of tests that you can do, right from the direct methods, including the virus isolation, genome detection, and antigen detection, and the indirect methods, which are the antibodies, so the IgM and the IgG. So as you move along the spectrum, your specificity will become lesser, but the availability of the test becomes more. So as you all know, the antigen and antibody tests are more widely available compared to if you wanted to do a virus isolation or genome detection by PCR. So it's also always important to understand how to interpret a test based on the timeline of the different components of the what you are testing. So in primary dengue virus infection, I think you must have heard that there's 4 serotypes. Theoretically, you can get infected 4 times, but most of the time the clinical manifestation is maybe the first and the second infection. So in a primary dengue virus infection, during the febrile phase, between 5 to 7 days, or minimum of 32 hours, but up to 5 to 7 days, this is when your virus is circulating. So if you do a test, it will be targeting towards the virus. So you either do a PCR, the dengue test, or NS1 antigen. So the first 3 days especially is the critical time for you to do the NS1 test, which is more available, obviously, compared to the PCR test. But as you enter the critical phase, that's when your antibody starts to appear. So the IgM will start to come in, and only in the recovery period, that's when your IgG will start to come in. That's for primary dengue infection. In secondary dengue infection, so the NS1 and the dengue virus PCR, if you like, will be similar, fairly similar to the primary dengue virus infection. However, because it's a secondary dengue infection, your IgG tends to come up much earlier, trying to neutralize this new infection. And therefore, your IgM may not be detectable in about 20% of secondary cases. So it's important to understand the timelines and how the different components behave when you compare primary and secondary dengue infection. So before I further go into the NS1 test, IgM, IgG, I'd like to touch a little bit on the role of full blood count. Full blood count, where you can get the hematocrit, white cell count, and platelet count, is useful for diagnosing dengue when you do it together with a diagnostic test. And it is also necessary for monitoring a patient who you think may have dengue or has been diagnosed with dengue. So as mentioned earlier by Prof. Lucy, when you do a serial full blood count, the white cell will drop first, followed by platelet count in the early febrile phase. And just doing a full blood count alone, if you see this drop in white cell followed by platelet, it would suggest that this could be dengue. In terms of monitoring, it's always good to have a baseline hematocrit. So another reason why you should do a full blood count early in the acute febrile phase. Hematocrit is also useful as a marker for plasma leakage. So a rise in hematocrit may suggest plasma leakage. But you have to, if you don't have a baseline hematocrit, then using population hematocrit may help you to agak-agak what the hematocrit is if you don't have a baseline. But more importantly, hematocrit can be used as a warning sign, but it has to be accompanied by a steep drop in platelet with a rising hematocrit. So don't look at hematocrit on its own, always couple it with your platelet count. The other features of full blood count, if you have leukocytosis and severe thrombocytopenia, this could be indicative of a severe disease. And there's no correlation between platelet count and prediction of bleeding. So we no longer do prophylactic platelet transfusion. So in the past, it used to be platelet less than 20, platelet less than 10. People will transfuse platelet, but we don't do that anymore prophylactically. Okay, so going back to if you have a patient with an acute febrile illness, who are the people that you should do a rapid test, a dengue diagnostic test with a full blood count? So that's the ideal, to do both together. So anyone with fever, with undifferentiated signs and symptoms, anyone with fever, with comorbid conditions, especially when they're still febrile, anyone with a warning sign, you should do it urgently, and anyone in shock. And those in shock, you also need to make sure that they're not diabetic as well. So these are the group of patients that you would, you need to have that low, especially if you're in the Klang Valley, hotspots area, urban areas, you need to have a lower threshold to trigger that full blood count with diagnostic tests. I always say with diagnostic tests because we often find a normal full blood count on day 1, day 2 especially. So if you just do a full blood count, it's normal. It might tell, you might end up saying, don't worry, it's not dengue, or I don't suspect dengue, and you would have that vigilance to keep testing or asking the patient to come back to do a retest. So if you do a diagnostic test together with a full blood count, you have a more robust diagnostic ability to say whether this is dengue or not. So these are some of the dengue-specific diagnostic tests that you can do. So as mentioned earlier, you can do the PCR, which is expensive, not readily available, and only used in special situations. You can do the NS1 antigen and also antibody detection using the IgM and IgG. So what is NS1? It's a non-structural protein of flaviviruses, including dengue. It's secreted into the bloodstream early in the infection. Day one of illness, you can detect NS1 antigen. So that's why it's one of the best early tests that you can do for someone who you think may have dengue. Oh, sorry. Okay, so NS1 antigen testing, as most of you know, there's a lot of point of care test kits now readily available. It's very fast. You can get a result within 15 to 20 minutes and fairly easy to perform. It doesn't tell you the difference whether it's serotype 1, 2, 3, and 4. Very good sensitivities, up to 90%. And it's best done during the acute febrile phase. So I wrote that day 1 up to day 5 and day to day 7. But really, the first 3 days is the time when the sensitivity is the highest. Okay, highly specific. If you have a positive NS1 antigen, it confirms the diagnosis of dengue. But a negative test does not rule it out completely. Okay, so never tell your patient, it's negative, don't worry, you don't have dengue. If you still feel clinically, you still have that clinical suspicion that this could be dengue, even if your NS1 is negative, you shouldn't dismiss it completely. Okay, but what's nice is that if it's positive, you know it's dengue, so you can tailor your management accordingly. Antibody testing can be the IgM and the IgG. It's an antibody response to the dengue virus. But again, you have to interpret it carefully. You must correlate your IgM, IgG with the day of illness to avoid any false negative or false positive results. So just a recap, remember in primary dengue infection, the IgM usually appears towards the end of febrile phase as you go into the critical phase. So, day 5 onwards. And the IgG comes in much later, and the secondary infection, you may detect the IgG much earlier, and you may not even see the IgM. So always correlate your serology test, especially when it comes to making it as your diagnostic test, okay? So you can see around day 5 to day 7 is like a window period. It's a period where your NS1 is waning off, your IgM hasn't really come up, and your IgG, if it's primary dengue, will not come up till much later. Okay, so that is the period where you might get a negative test for all three, NS1, IgM, IgG. But at the end of the day, clinical. If your clinical suspicion is still high, continue treating it as per dengue. Obviously, think about other differential diagnoses as well. Think about other possibilities. And look for other clues to help you decide whether this is dengue or not. Okay, so IgM is detectable in 80% of patients by day 5, 99% by day 10. It peaks at 2 weeks after onset of symptoms, and it can last for 90 days. So this is another thing. You have somebody coming in with fever, day 2 of illness, IgM positive. Doesn't really mean that that is dengue, because it could be from just a recent infection 2 to 3 months ago. But if the IgM is negative on during acute febrile illness, and then you repeat it and it becomes positive, then that could really be dengue. That shows seroconversion from a negative to a positive test. Okay. On day 5 onwards, if you have a positive IgM with the NS1 negative, so it also does not really necessarily confirm an infection. It is highly suspicious, but doesn't really confirm a positive that this is dengue. So you need to look at your clinical correlation, do a repeat test, and also if it's available, you can do a serology dengue PCR test as well. What about IgG? IgG is the secondary antibody. In primary infections, as mentioned earlier, it will come up towards the recovery phase and slowly increase, and it will be there for life. So if you have an IgG early on and clinically it looks like dengue, and if you have a NS1 positive as well, then this could indicate a secondary dengue infection. So there are combo tests out there. You can have just a serology combo test, IgM, IgG, or you can also have all three, NS1, IgM, IgG. Okay, so if you know you're in that acute febrile period, just doing an NS1 would be sufficient. If you want to do all three, is also okay, so that you can have a better picture. But the key is to interpret it carefully with the day of illness and the clinical history. Okay, so what we're doing in clinics, in primary care, is basically the rapid diagnostic test, NS1 antigen, IgM, IgG. But the lab also does a more sensitive test, which is the ELISA test, and there are some pros and cons of each test. Obviously, the one that we send to the lab, the turnaround time will be much longer, and you won't get your results immediately. The RDT that you can do by the bedside, you can get the results earlier, but there might be a lower sensitivity for that test. Now, the whole morning you've been listening about vaccination, right? So how do we test somebody who's just been vaccinated? So in the first 30 days, that's the period where it's going to be most difficult to diagnose somebody, whether they have dengue or not, if they've just been vaccinated. So up to 30 days, you can use the PCR and even the NS1 antigen. It might be useful, okay? It might still be useful even though you've been vaccinated. But the serology should not be used as a confirmatory test, okay? But at the end of the day, I think we're going back to when we didn't have the combo test. You have to rely on your clinical evaluation and judgment. You have to look at your full blood count. You have to look at the signs and symptoms as explained by Prof. Lucy earlier. So don't rely on the test alone. It's always with combination with your clinical evaluation. Some primary providers, especially emergency department, they have this bedside ultrasound. I don't want to spend too much time on it, but I think some of you may come across it, and some of you might be very good with ultrasound and feel that you want to use it. Personally, I don't think it should be used unless you are trained and competent to do it. And personally, I think the major role is to use it to detect early plasma leakage, which is either by gallbladder wall edema or looking for fluid in the third space. Okay, there are many pros and cons to it, but personally, I feel the ultrasound should be reserved in ED and in places in ICU, and also in places where the personnel are trained and competent to use it. Okay, so that's diagnostics. Now I'm going to move to the case classification of dengue. So this is to give you an overview of how we classify someone who may have dengue. So you've gone through the history, examination, the clinical course of dengue, and at the end of the day, you ask yourself the blue box at the very end: could this be dengue? So some of the clues based on the history of whether this person may have dengue is basically somebody who's lived or traveled in a dengue endemic area and has symptoms which may be suggestive of dengue. Fever with nausea, vomiting, rash, aches and pains. If you're still doing the tourniquet test positive, we don't do that anymore. And if you do a full blood count, if they have leukopenia, not thrombocytopenia, but leukopenia, because that's the first thing that comes down, and if they have any warning signs. So this is very important. At the end of the day, we don't really want people to just dish out the NS1 test, right? You have to have a little bit of clinical suspicion there as well. I mean, not a little bit, but a lot of clinical suspicion, because what happens is that we've had cases where, you do the NS1 test, if antigen positive, okay lah, you can say that this is dengue. But again, it doesn't mean that it's a severe dengue. It doesn't mean that you have to send them to the hospital immediately. It doesn't mean that you need to start IV fluid immediately. The other ones is, you only have an IgM that's positive. Then you send to the hospital because you think it's dengue. And you completely, don't look deeper to look for the actual cause of the fever, okay? So clinical suspicion must start first, must be there first. And then if you think there's a high clinical suspicion for it, especially if you come from a place that's had a lot of dengue cases, I mean, you all are GPs, some of your GPs, you know what kind of patients are coming to you, right? You have a feel that, oh, I'm seeing a lot of dengue this past few weeks. Then do the test, okay? I'm going to come back to this later. So some of you may remember or may have heard of this old classification. So this is the 1997 WHO dengue classification. The reason I'm putting it up because some people still use this, where they classify patients to dengue fever and dengue hemorrhagic fever, where dengue hemorrhagic fever represents the more severe forms of dengue, DHF 1 and 2, and also dengue shock, which basically focuses on plasma leakage. So in 2009, WHO came out with a new classification where we are shifting away from that kind of classification, and we're looking at patients based on the severity of their symptoms and signs. So they realized that dengue has a wide spectrum of clinical presentation. Most are self-limiting, and only a small proportion have severe disease, which is usually characterized by plasma leakage with and without hemorrhage. So the new classification, 2009, or not so new lah, hopes that it will help clinicians when they see a patient, they think this patient may have dengue, they can decide there and then whether the patient has any signs of severe or non-severe dengue. And that will help you with your decision making in terms of what do you do with this patient. Do you keep them in the hospital? Do you keep them in the community? Do you follow them up daily? Do you quickly pick up the phone, send them to the hospital? Or do you just send them with a referral letter? In the hospital, do you want to start IV drip? Do you just give them oral fluid? Do you bring them straight to ICU and so on? So this new classification helps clinicians to better prognosticate the patient and also decide on the treatment or management. So patients are classified as dengue with or without warning signs and severe dengue. Okay, so as mentioned earlier, your first point is, do you think this could be dengue? And we've talked about the symptoms and signs that is suggestive of dengue and some of the laboratory tests that you can do, including your NS1 as well. So once you've done that, what I usually do is, if they're in the critical phase, I ask myself, does this patient have any features of severe dengue? So what are the features of severe dengue? When they have severe plasma leakage, i.e. they are in shock, or they have a lot of fluid accumulation causing respiratory distress. So we're talking about pleural effusion, ascites. Do they have severe bleeding? Bleeding that causes hemodynamic instability. So we're talking about upper GI bleed, lower GI bleed, per vagina bleed, which causes hemodynamic instability, and they may require some blood transfusion. Or do they have any severe organ impairment? So commonly is the liver, followed by the CNS and other organs like cardiac. If they don't fall into the category of severe dengue and they're in the critical phase, then you ask yourself, does this patient have any warning signs? And Prof. Lucy has already elaborated on all the warning signs that you need to be on the lookout for. So 1997 WHO case classification, even though it's been superseded by the 2009, some people still use it, but they've added on a component called severe organ involvement, which to me is just the third category of the severe dengue. Just to say that even the old classification also still includes severe organ impairment as one of the criteria for severe dengue. and this is the Malaysian CPG. We're going to come up with a new one. I think the main thing is that we no longer put diarrhea as a warning sign. Okay, so prophecy has gone through step 1, step 2. We talked about the phases of disease. We talked about the severity of disease. We talked about investigation. So at the end of it, we hope that by the time you've seen the patient and done the appropriate investigation, you'll be able to tell us whether this patient may or may not have dengue. Is it confirmed or not? What is the phase of illness? If the patient has dengue, what is the phase, whether it's febrile, critical, or recovery? And what is the severity, especially if they're in the critical phase, whether they have warning signs or whether they have severe dengue? Okay, so these are the things that, at the end of evaluation, you need to be able to answer this. Yeah, these questions, then you can move on how to manage the patient. So the whole point of the first 2 lectures, the first one is clinical cause and assessment, and then this lecture about diagnosis and case classification, hopefully will help you to approach your patients better, those who have febrile illnesses, acute febrile illnesses, and hopefully it will help you to assess them better and finally be able to classify them accordingly before you can decide on what to do with them next. Okay, so step 5 would be management decision, which we'll be talking about in the next 2 lectures. Okay, so just an overview. Once you've done that, you can group the patients into group A, B, and C. So A are patients who you can send home. So patients without warning signs, patients with no comorbidities, patients who do not have severe dengue. Okay, so these are patients who are able to drink well, passing urine well, has no warning signs, has stable hematocrit, does not have comorbidities, able to come back daily. So this is important. They have to come back daily, not just for clinical assessment, but for repeat full blood count. Group B is the one that you need to send to the hospital. So patients who have warning signs or patients who have other comorbidities that needs closer monitoring, or they can't come back daily. And finally, patients group C are those who need to be sent to the hospital immediately, requiring emergency treatment. So the 3 categories of severe dengue. Okay, I think we have a bit of time just to go through some cases. So this is a 30-year-old unemployed gentleman. History was taken from the mother because when he came in, he was unconscious. Fever for 3 days, lethargic. He came down for breakfast at 9 o'clock, but he was looking a bit lethargic, went to his room. When the family went to call him, he was unconscious. He was not responsive at 10 o'clock, so they called the ambulance. When the ambulance came, he was unresponsive, GCS only 3 out of 15, pupils 3 millimeter reactive. Lungs, CVS, and abdomen examination were unremarkable. His BP was 101/51, heart rate was 180, respiratory rate was 40, SpO2 98%, the room air dextrose was 10.8. So he's a 180 centimeter, 80 kilo guy. So tall, big, but not like completely overweight or obese. So they put him on high flow mask, they start a line in, and they ran 1 pint bolus quickly. So when he arrived in the hospital, about half an hour later, his GCS was still 3 out of 15, but his capillary refill time was okay, warm peripheries, warm to touch, and good pulse volume. And his blood pressure was 126/62, pulse rate 180, and and he was febrile at 41.3 degrees Celsius. So he was actually in SVT, so they quickly did a point of care test because he was febrile. This is day 3. And as you can see that the point of care test, the white cell was 3.6 low, the hematocrit was 43, and the platelet was 130. The gases, VBG, lactate was 5 with a bicarb of 19. And this was a dengue combo test. all panels were negative. So is this dengue or not dengue? If you were in ED, or even if this patient came to your clinic, dengue or not dengue? Could be dengue, right? Could still be dengue. That's what I want to hear. So just because it's a negative test, if clinically it's still suspicious, it could still be dengue. All right? Okay, so they did a point of care ultrasound which did not show any fluids in the lungs or the abdomen. IVC was 1.2 cm. I usually take this IVC reading with a pinch of salt. So luckily, in the emergency department, they still treated it as probable dengue fever, severe dengue, with dengue encephalitis or dengue myocarditis, and it was also in an SVT. Okay, so okay, quite good. They're not like dropping the dengue diagnosis just because the combo test was negative. What other information will be important or useful in the ultrasound test? Ultrasound focus, do you think it's okay? It's useful? So no ascites, abdomen, they didn't mention anything about fluids. Gallbladder wall thickening, okay? So if you think this is dengue, you think they collapsed because of plasma leakage, then look at the gallbladder wall thickness. That's the earliest sign of plasma leakage. So they intubated him, they cardioverted him, and started him on amiodarone. And post-intubation, there was actually some coffee ground in the Ralph's tube. They still treated him as severe dengue and added on upper GI bleed because of the coffee ground. Okay, and this is his, so they ordered a whole lot of tests, all came back negative. And this is his chest x-ray. What do you think? 180 kilos, 180 centimeters, 80 kilos. Any comments on the chest x-ray? So the heart, it may be a little bit underfilled. Okay, I mean, it's not the best chest x-ray, but for a 180 centimeter, 80 kilo guy, that heart ratio looks a little bit small. It could be suggestive of undervolume. Okay, so medical came down. They decided to change the diagnosis to gram-negative sepsis. And they even wrote that unlikely dengue fever. I do this also sometimes, okay? The reason is because it's only day 3 of fever. They would have expected the NS1 to be positive, but it's negative. The platelet was a little bit high for someone with severe dengue. And he also had this history of this UTI that's been going on for 1 month, which I didn't include here. But despite that, they still sent for another dengue combo test to the lab. But do you know why was the reason for sending another dengue combo test? I don't have much time, so I'll jump into it. Because they wanted to denotify the patient, okay? So I think there's no rush to denotify patients, okay? It's not like PKD is going to come and knock on your door and ask why you didn't notify. So to me, there's no rush to denotify. So don't send the repeat DCT for the wrong reason. But this lab, even the lab diagnostic test was negative. So, bukan dengue lah. No, even if your second test is negative, if you clinically feel that it could still be dengue, go ahead, all right? But it's not wrong to think of other differential diagnosis. Okay, you also don't want to miss anything because at the end of the day, there's no magic bullet for dengue. But if you do have a gram-negative bacillus, you have to start your antibiotics and so on. So I'm not saying that you should just entertain dengue. You should think of other differential diagnosis as well and start treatment if you think it's indicated. So the lab, because he had a negative test, the standard protocol is to proceed with an ELISA test. And the ELISA test, IgM, even though it's IgM, came back positive and the results only came back 2 days later. So this was the amount of blood that was coming out from this gentleman. And just to show you how bad his bloods were, lactate was very high. The platelet, the initial 130 was a point of care test, but the actual platelet, when they did it in the lab, was actually 54. Hematocrit was low, reflective of the bleeding that he was having. Unfortunately, he collapsed in ED twice and finally died at 8 p.m. on the same day. Our takeaway message from this particular test, and the other thing is that he actually had a post-mortem because nobody wanted to believe that he had dengue. People were like, why did he bleed so profusely and whatnot? So he actually had a post-mortem and PCR was positive. PCR was positive in his lungs and also his liver. So this is a confirmed dengue. So some people might come to me and say, "Alah, IgM, you're positive, it's not dengue, right?" But his PCR was actually positive. So because of the unclear diagnosis, unfortunately, this patient, when he was in ED, there was no clear indication who the primary carer was, and we felt that the blood transfusion decision for OGDS were delayed, and that could have contributed to his death. Okay, thank you very much.
Thank you, Rifah. We have a few questions. If there are any questions from here, just put up your hands, yeah? There's one question here. Why is diarrhea no longer put as one of the warning signs of dengue?
Okay. So, just a bit of history. The warning signs were not just plucked out from thin air. How WHO came about with the warning signs is when years ago they actually did a prospective observational study called the dengue study. They followed up lots and lots of thousands of dengue patients from the time they were admitted until they were discharged. And then they looked back and looked at what are the common signs and symptoms that patients presented with. So if you look at the WHO guidelines, diarrhea is not there because diarrhea is a very common symptoms that almost every dengue patient has, and it doesn't help you differentiate between a more severe and a self-limiting dengue case. Okay, why Malaysian CPG added it on, I don't know, because I was not in that CPG, but that the current CPG we have dropped it because it's actually not a recognized warning sign.
Okay, one, yeah. For a patient, day 8 illness, resolved fever, vomiting and diarrhea persists, history of dengue infection many years ago. This time tested NS1 and IgM negative, IgG positive. So is she having dengue infection now or is it an old dengue?
So day 8 of illness, even if he had dengue, is already in recovery. So this IgG could represent the recovery IgG for this particular episode. But it could, even if it's an old dengue, it's already day 8 of illness. If he's still having vomiting and diarrhea, probably need to look for other causes lah.
Okay, just one last one. There's so many more. How do we exactly interpret the point of defervescence just by looking at FBC when the patient present to us with no fever? Do we see when was the last PCM intake or FBC count?
Okay.
And the nadir for platelet. There is a nadir.
Yeah. The cantik graph is what we saw from Prof. Lucy's presentation lah, right? Temperature comes down, 38, and all that. But in reality, even in the hospital, we have a lot that I think a defervescence already belum lah, and then we keep changing. It's fine, we keep changing because you keep reassessing the patient, right? But generally, it'll be between 72 hours, after 72 hours, up to 7 days. That's the point where they can go into defervescence phase. And that's the time when you think about, is there any significant leakage or not, okay? It's also called the critical phase. It's also called the critical phase because if the patient has significant leakage, they are at risk of significant plasma leakage and also going into severe dengue, right? So that's why it's just a time for you to be cautious about, okay? So how else can you think? So how I do it is the moment the temperature drops, I look at the patient. If the patient is getting better, very unlikely they're going to go into critical phase and have significant plasma leakage and so on. They're probably just going to go straight into recovery phase. But if they're not quite better, then you know that, hang on, there's something else going on here. Now, how do you decide on the effervescence point? Yes, temperature is number one. Number two is when your white cell is the lowest. But again, how do you know the lowest? You have to wait for the next one before you can say it's the lowest, right? And also when you have this sudden drop of platelet, you're doing your platelet, suddenly it drops. So if the platelet drops below 100, that's when you have to think about, oh, maybe he's already in the critical phase now. So there's a few parameters that you can use. Okay.
Do you want to take that last question?
What is the reference range? Smokers. No, there's no, there's no reference range. But again, never treat anything in isolation. Okay, we have so many refer because NS1 positive and hematocrit 54 day one, right? Day one, that could most likely hematocrit 54 is their baseline hematocrit. Kenapa? Kena tanyalah. Dia smoking ke, dia naik gunung hari-hari ke, we don't know, okay? But look at the clinical context, look at the timeline. Timeline is very, very important, okay?
But still, you should refer, right? I mean, you're not going to discourage them.
No, I don't know. At the end of the day, what is your criteria for referral? Your criteria for referral is either they have warning signs or they have comorbidities, okay? Yes, you can argue someone day 1 to day 3, they're so febrile, they're so viremic, they're vomiting away, they're dehydrated. Fair. But don't say this patient is in shock lah, because the way you treat them will be different. Because the moment you refer someone in the febrile phase and you label them as warning signs or you label them as shock, you're going to get 20 cc per kg, which we don't want. Okay, yes, they might be dehydrated, they might need a bit of fluid, but you don't need that, huge boluses of fluids.
That's true. Okay, but I think as a general practitioner, primary care, if they have a doubt, they can send to somebody like you, and you can assess them better.
Yeah, agree. I mean, if you are in any doubt, pick up the phone, speak to your clinic kesihatan, speak to your ED, send them over, you're still unhappy.
Okay.
Yeah.
Thank you very much. So the idea is for you to actually refer patients and, so that we get early detection. Okay, you look very tired. You want to take a 1-minute break, stand up, stretch your legs first, people. Just stretch your legs a bit, and then we can continue with the next talk, which is going to be pretty heavy again. Yeah. Take a break. Tough to keep the concentration. You see the thought. During the presentation, the callers. I think we better start because otherwise. All right, and the next talk is by Dr. Ong Hang Cheng, who is a consultant infectious disease physician from UMMC, and he's going to talk about outpatient management. Dr. Ong?
Good evening, everyone. Thank you, Dato, for having me here. And it's always a privilege to share the stage with my mentors, Prof. Lucy and Prof. Sharifah. So I hope everybody is awake. Well, do you realize the case that was shared by Prof. Sharifah just earlier was giving more palpitation than perhaps the World Cup finals later? Right, that's what we feel when we manage cases like that. Right, so today I'll be talking to you about outpatient management of dengue fever. So I think this topic will be relevant for all the participants who are with us today. So before we begin, I would like to highlight some important points on outpatient dengue management. Firstly, there is still no specific antiviral treatment for dengue. Our management remains entirely supportive. And the good news is that severe dengue is largely preventable. Early recognition, appropriate fluid management, careful monitoring, and timely intervention can dramatically improve patient outcome and reduce case fertility rates. The third point is most patients with dengue do not require hospital admission. If you pay attention to the talk by Prof. Lucy early, not many patients who has dengue progress to severe dengue. However, outpatient management is much more than simply deciding who can go home. It involves ensuring that patients receive the right advice on hydration, on fever management, on daily follow-up, recognition of warning signs, and recognizing patients who are at risk of deterioration, and ensure that they are referred promptly for inpatient care. Okay, so what are the keys to good clinical outcome? So we need to recognize the dengue and differential diagnosis early. And secondly is identification of clinical problems during the different phases of dengue. For example, early recognition of shock is important. And a rational approach to case management, like outpatient and home management of dengue versus inpatient management of dengue and early management of shock. So this is some of the key to good clinical outcomes. Now let's move on how do we actually approach a patient with suspected dengue in the outpatient setting. So every patient should undergo a systematic assessment before management decision is made. So I find it very helpful to think of this as a simple 5-step approach. Okay. First, we must always remember that we are clinicians. We must always go back to history taking, take a good one, take a complete one. And secondly, don't forget the magic touch, the 5-in-1 magic touch, the CCTVR. So this for us as clinicians in the hospital, it's our bread and butter. We do this properly every day. We do not miss this. So because if you remember Prof. Lucy's talk, by looking at the patient is not enough, you have to touch the patient. So we touch by coming back to this 5-in-1 magic touch of CCTVR. And third, obtain the appropriate investigation. I'll come to that later. And diagnosis with, and the fourth, determine the patient's dengue phase and whether there are any features. Why is the slide moving by itself? I'm sorry. Sorry. Yeah, determine the patient's dengue phase and whether there are any features of severe dengue. Then based on all these 4 steps, we come together, put everything together, and we can actually put the patient into one of these 3 categories, whether they are in group A of dengue fever, whether in group B or group C. Group A is a patient who are not requiring hospitalization. Sorry, let me just go back. The slide just play by itself. Okay, I think I'll just, okay. And group B will be to refer for hospital management, and group C will require emergency treatment and urgent referral. Okay, so before deciding on management, every patient should have a dengue assessment checklist completed. So there is a checklist in our Malaysian CPG at the back, at the appendix there. So this is one of the assessment checklist that you can refer to if you wish, to help you to put the patient into which category of dengue that the patient is in. So today I'll be focusing about outpatient management, all right? And group A is the patient that can be sent home, right? But we have to make sure like the patient actually meet all these criteria before we can safely send the patient home. Because how do you know whether the patient is going to get worse at home if they are not properly counseled and not getting the adequate advice that they need, when to come back to hospitals, how much of fluid that they need to take. I'll focus on that today. So the intake of the fluid and oral intake, we have to make sure like the patient gets adequate volume of fluid intake. All right, and pass urine at least once every 4 to 6 hours. Okay, sorry, this is a bit too much. And does not have any warning sign and have stable hematocrit and hemodynamic status, and they do not have any coexisting condition. All right, so we have to make sure like the patient drinks enough. So the good question that we can counsel the patient is, we have to make sure like they drink enough so that they pee enough. Okay, this is something that the patient can understand easily and is very helpful. Then we have to go on and take the patient's full blood count. So we have to have a baseline of what they have at that time. Particularly important and useful if they come during day 1, whereby if we have a hematocrit or HB during that time, it will be their baseline. Okay, then we need to confirm whether it's dengue or not. Nowadays we have the privilege of getting this bedside NS1 test, especially on day 1 to 3. If it's positive, then it's highly likely that it is dengue. So it can give us a very good diagnostic for dengue. Then next, we need to give the patient some guidance before sending the patient home. And number 4, we have to educate on the patient about the effervescence and the warning signs that they need to look out for at home. And we have to monitor the patient daily for progression to severe disease. So this will require the patient to return for clinical assessment. And then we have to do a serial ECG daily. So keys to good home care will be bed rest, of course, and we have to encourage oral intake, right? But not just encourage oral intake, because what is adequate oral intake? Because if we say like you go back and you drink more, so what is more? What is adequate? And then what kind of fluid do you take? Do you take like sweetened drinks, canned drinks, and so on? Are these considered good fluid for them for this oral intake that you are encouraging? So I'll come to that. So instead of encourage oral intake, we should actually prescribe oral intake, prescribe the fluid and educate them about the dose of the fluid that they have to take at home. So just like we prescribe medication, paracetamol, for example, 2 pills, 4 times a day max, that kind of prescription, it should be prescribed oral intake. So the rule of the thumb is 6 to 8 glasses of fluid, each glass about 220 to 240 mils of fluid for an adult, and accordingly in children, right? So what kind of fluid is good for them? So we need to make sure like the fluid is not just plain fluid. Things like reverse osmosis fluid is not good for them because there is no electrolytes in them. So we have to always make sure like the fluid that they take, that they ingest, has all the nutrients, have all the electrolytes in them. Good examples that we can encourage the patient to take are things like coconut water, ORS, barley water, rice water, or clear soup. Because if you encourage them to just take water alone will dilute all the electrolytes like sodium and potassium, and you may see that they become lethargic and so on, and it can cause electrolyte imbalance. So we have to encourage them to take fluid with electrolytes, okay? So coconut is a good example. It's a natural rehydrating fluid. It has a lot of electrolytes, but of course we have to make sure like the coconut is fresh. It's not expired coconut, okay? And if we look at this photo, we have to make sure like they take the coconut water that is fresh and not like in cans or in packets that has additives in them. So if you look at here, even the coconut gula muda here, it's added with sugar, right? 9.9 gram per 100 mils. So this is not good. And if you look at an electrolyte drink, I cannot say any brand, it's 13.5 gram per 250 mils. So we can have problem if patient take a lot of high sugar content drinks, right? Because if they take high sugar content drinks, then we can actually promote osmotic diuresis by the patient passing out, sugar in the urine. So actually they can lose more fluid when they take sugary drinks instead of getting more. They're actually passing out more. So this is an interesting study that looks at the types. I mean, this study design looks at the oral rehydration therapy in dengue. Oh, sorry. So it looks at 138 patients more than 12 years of age. So they look at fluid chart and the number of cups that they drink per day, and versus the usual care without structured hydration guidance. So basically, this study looks at two groups of people. One is just like encouraged orally. One is like they prescribe the oral fluid. Sorry, the slides are a bit jumpy. So the hospitalization will be, then they look at the outcome, as in whether the patients in group A is hospitalized more, or the one just prescribed fluid is hospitalized more. So interestingly, those who are prescribed oral fluid, as in they are advised as in how much you need to take, like a prescription, they have actually lower hospitalization compared to the group that is encouraged to take orally but without specific instruction. Okay, although statistically it's not significant, but I feel that it is still a very significant and interesting outcome that we can see from this study. And the take-home message from here is structured encouragement, as in prescription of the oral fluid rather than just a general encouragement of fluid intake, can actually help the patient and prevent hospitalization. Okay. Okay. So how much do we have to ask the patient to drink? So this slide will let you have an idea. Let me go through this with you. You can see like, so it is encouraged that for every 2 hours, the patient is encouraged to take 1 cup of fluid. And 1 cup is about 240 mils of fluid. So if you look at the clock, like when you wake up in the morning, let's say at 6 a.m. up to 6 p.m., it's three cups should have gone in. And right, so for every 6 hours, you should have the patient drink at least 3 cups of water. Okay, or in another form of calculation, you have the patient to drink half cup every 1 hour, which is about 120 mils for every hour. And this has to be a proactive process by the patient. So they have to chart it down, okay, how much they drink, at what time, what do they drink, and also chart down the urine output. How much do they pass out at what time, so that we have a clearer idea of how much IO have gone in and what has come out. So this is what we call as empowering the patient to document the input and output. And we would have given the patient a chart like this, a simple chart that we also use in our wards for our inpatient, those who can drink and all that. So we will educate them on how to chart on this graph, on this chart, like the time of the day, how much drinks, what was given, and so on. Oh, sorry. Okay, and type of drink, and also the urine output and frequency. Okay. Right. So after we teach them about how much to drink, what to drink, how to chart it properly, we also need to manage the fever, because we know that fever in dengue patients can be very disturbing as well, especially the fever is high, more than 38 degrees Celsius. So we must always remember that in dengue patients, we often see transaminitis, inflammation of the liver, right? So if we were to give like paracetamol for fever control, we must make sure like it's not more than 4 grams per day, and it should not be prescribed like a regular PCM, like 1 gram QID per se. It should be like just on a PRN basis as needed, okay, as needed. And remember, do not give NSAIDs like ibuprofen or aspirin, because this can actually lead to GI bleed and bleeding tendency if the patient progress to critical phase, and if the disease take a turn for the worse, okay, then that can lead to bleeding. We have seen this in real cases. And of course, tepid sponging can be done as well. Other than all that, make sure like we also educate the patient when they recover, or the family members, to get rid of breeding habitats around the home and to kill adult mosquitoes as they see it. And if they do not improve, or if there is presence of warning sign, make sure like they return to the hospital immediately. So warning signs like frequent vomiting, unable to drink, reduce in the urine output, severe abdominal pain, tiredness, drowsiness, confusion or seizure, which are late signs of this shock, pale, cold or clammy hands and feet, and breathing difficulty, they must come back immediately. And of course, if there is bleeding like red spots or patches on the skin, bleeding from the nose or gums, vomiting blood, dark colored stool or melena, heavy menstruation or vaginal bleed, so they must come back. So steroid should be avoided, because this can also lead to GI bleeding. NSAID also should be avoided, so do not give NSAID, especially IM, because sometimes we get referrals who come in, was given IM Votrient in the clinic, for example. Then we see like big hematoma at the injection area, and that hematoma can lead to problem later on. And antibiotic, remember, this is a viral infection, so antibiotic is not necessary. So there are 3 golden questions that we have to educate our patient when we send the patient home. So we have to always ask them as well, like how much oral fluid can they take in the last 12 to 24 hours. Next, after they take the oral fluid, how much urine output, you know, whether they can pass urine every 4 hours, every 6 hours, or they don't pass urine at all. That should ring a bell to us to send the patient to the hospital, okay? And what activities can the patient do, right? So activities like if they can still walk around, they can still walk to the toilet to pass urine, or whether they are too tired to even walk to the toilet to pass urine, you know, this will give you a clue as to how severe is the dehydration, or how severe is the plasma leakage, or the volume status in the body. And of course, we have to identify if the patient is still in the is in the febrile phase or the critical phase, and we have to also, educate the patient about the warning signs. And when we see them, always touch the patient. The magic CCTVR is very, very helpful. All right. And for the laboratory investigation, rapid combo test or NS1 antigen will be positive in the first 1 to 3 days. If it's positive, it's helpful. If it's negative, well, we have to be careful to discount dengue diagnosis, put everything together, history, physical examination, and so on, and not to dismiss it too easily, like, okay, it's not dengue, you know, so it can be dangerous, like, can be still dengue. And of course, serial full blood count until patient is out of the critical phase. So we can see the trend, like the white cell will continue to drop, as well as the platelet. And if we see a rising hematocrit rapidly, then that should ring a bell. And also concurrent fall in platelet count with a rising hematocrit. It should bring the patient back soon. And before we discharge the patient from our outpatient clinic, we should make sure like they receive home care advice. They should receive also a dengue monitoring card and also a follow-up appointment card. So home care advice like this from our CBG can be helpful, or if you have your own in your clinic or your hospital, you can use that as well. And this is a dengue monitoring record. For example, you know, they have the different dates, the day of fever that the patient come to you, what is the temperature like when you see them, the blood pressure, the pulse rate, the hematocrit, and the white cell and the platelet as well. So the next appointment is there as well for you to fill in. And of course, if the patient might go to different clinics if they travel or so on. So if we have the contact number or the clinic that sees them in the card, it will be helpful. So we should refer them to the hospital if they have warning sign, bleeding manifestation, they are not able to tolerate orally, reduce urine output. Of course, if they have other warning signs or, you know, signs of shock like seizure, lethargy, all that are signs that we need to bring the patient to hospital fast. And signs of dehydration, shock, bleeding, or organ failure, needless to say. Special situations like these, even without warning sign. So we may have patients with multiple comorbidities, for example, if they have diabetes, hypertension, ischemic heart disease, coagulopathy, morbid obesity, renal failure, chronic kidney disease, COPD, and so on. Or if they are more than 65 years of age, or if they have been on anticoagulant, for example, or antiplatelet, or pregnant, or if they are living far away from hospitals, they do not have transport to come if they need to come to hospital, or if they are living alone. So all these criteria, we have to consider to bring them, to admit them rather than manage this group of patients as outpatient, because deterioration can happen. And if, for example, even they don't have warning sign, if there is warning sign, nobody to bring them to the hospital, they can actually progress and get worse at home, okay? And laboratory criteria, if we see like on your daily serial monitoring, there's this rapidly rising of hematocrit with marked reduction in the platelet count, you want to consider to bring them in as well. Okay, next is dengue is a notifiable disease. It has to be notified within 24 hours, and you can notify it using the e-notification system. Okay, so nowadays they will fine you if you don't notify within 24 hours. So myself have been fined once, and I just want to share with you, this is the compound that I get, 1,000 ringgit. I saw the patient in the private wing. I just saw him once, and I get this compound. It happened on a Saturday. I fill out the form, everything, get the nurse to send over, but the form actually reached the PKD on a Monday morning. So it's more than 24 hours. I wrote in, I pleaded with the PKD, rayuan, etc. So tidak dilayan, so had to pay. So I mean, the point is, I can understand why as well, because they need to do the mitigation, mitigation protocols, fogging, and so on, right? And that is why they are very strict with this. So just remember that, don't forget to notify and make sure it reaches them within 24 hours. All right. So the summary of management of dengue fever, we can fall back on this table, whether it's group A that we send home, or group B, inpatient management, or group C, urgent management in the emergency, come immediately to the emergency, right? But if we manage the patient as outpatient, like we have just gone through the talk, we have to give them guidance before sending home, follow up plan, okay, daily CBC and assessment until they are out of the critical phase, and we have to educate them about the warning signs, and we have to educate ourselves about identifying the warning signs early, okay? So moving forward, prevention of these abnormalities should be the focus of management during the febrile phase, from the febrile phase onward, and not to like wait until the patient get at the febrile phase, not given advice to hydrate adequately and progress to worsen during the critical phase. So we encourage, not encourage, but we have to prescribe fluid, electrolytes, soft diet, in the febrile phase. And we have to emphasize on fluid that contain electrolytes, and we have to prescribe an adequate patient on documentation of intake and urine output, and monitor oral intake and urine output, and urine color at home. You remember the slide that Prof. Lucy has shared? And we have to get the patient to seek treatment at the point that if they are not able to tolerate orally, okay, despite being forced by their family members, okay, they still cannot tolerate, they must come lah, or reduce urine volume, or increase in the concentration of urine. So when we see them, if they have all this documented properly, then we can, just like in the ward, we can actually have a chart to review objectively. So it's not like guesswork, it's not like guessing, it's all objective. So I would like to acknowledge Prof. Lucy and the ID unit of PPUN. Thank you very much for your attention.
Thank you, Dr. Very quick questions, all right? This one, misconception here. He says here, correct me if I'm wrong, that not all patients will go to critical phase. Some patients will, from febrile, go to defervescent phase. Is that correct? And patient can be diagnosed, treated, and discharged from primary care.
Yeah, that is true. Right, and even there are patients who are asymptomatic.
Okay, right. Okay, next one. Just want to ask if the dengue patient... What is this? Somebody go and change this. No, it's not. It's gone into this poll. Okay, the other question is, if I remember correctly, if is 100 plus?
Well, 100 plus is a brand name, so that contains electrolytes, but the sugar content in it also is very high.
He said sugar less sugar.
Yeah, I think there is one that is zero sugar, and the other thing you want to consider is zero gas as well. Zero gas, zero sugar, I think that will just contain the electrolytes.
Okay.
Oh, but that one no potassium according to Prof. Lucy.
All right, yeah. Okay, this one is all patients with comorbidities, despite good control of comorbidities, still need to be referred to the hospital.
So depends on the case as well. I think we have to go by case basis. Of course, that is under the category
general rule
B.
for the GP.
General rule.
Need general rule. Microphone.
Yeah, I think the CPG is very vague and just says diabetes, hypertension and whatnot, kan? But we do understand if you start referring every single patient with comorbids to the hospital is going to be overwhelmed and they can't cope. So I think the key is uncontrolled. So if you have a diabetic who you know is on insulin, for example, or their last HbA1c is like 8 point something, then these are the ones that you probably would, multiple comorbidities, you probably want to refer those to the hospital for closer. But if it's a diabetic on one OHA, doing well, still eating and drinking, I wouldn't necessarily ask you to refer to be admitted.
So not all with comorbidity should be referred, right? Okay. If a patient with IHD on aspirin now having dengue fever, should aspirin be withheld, or for how long, and how long should it be withheld?
So we have to look at the patient again. How bad is the dengue and how low is the platelet? And it's a difficult decision, to be frank, because on the one hand, if we stop the platelet, you are thinking whether the IHD is going to come, is the patient going to get a heart attack? Or on the other hand, if you continue the platelet, is the patient going to bleed? So which one is more severe at the point in time?
So I think the general rule is if your platelet is above 100, there's no rush to stop it. Once it goes below 100, you may want to stop. But the one group that you would not want to stop is those who just had a PCI in the last 6 months, because there's a risk of stent thrombosis in those cases. But again, remember, aspirin half-life is 7 days. So even if you stop it, it's probably not going to cause much problems. And remember, you can also get upper GI bleed ulcer if you do continue with the aspirin, they have dengue. So I would probably err on stopping because of the long half-life, risk of upper GI bleed and whatnot. The only caveat is the one that just had a PCI. So this one you have to talk to, obviously you're going to refer to the hospital admission and talk to the cardiologist about it.
Okay, good. All right, this one, last one. All right, this one is a practical question. If the dengue patient is well, if the dengue patient, okay, let me remember if the dengue patient is well and no fever or something, and then the platelet is 58. Where is it? 58 only. Could we treat as outpatient? If dengue patient is well, no warning sign, hemodynamically stable, claim oral intake is good, but platelet is low.
Yeah, so remember that dengue is not a platelet disease.
Yeah.
Yeah, so we have to look at the patient and at what stage, comorbid, the risk and all that. So can still be managed as outpatient if they are well, got good social support, can come to the hospital, and especially if they might be in the recovery phase already, that kind of thing. Yeah. So not necessarily like we just look at platelet alone. Okay, hope that answers the question.
Okay. Yeah.
It's a papaya leaf question.
Yeah, you want to answer that? You want to answer that?
No papaya leaf, no role whatsoever. We had a few cases a couple of weeks ago where about to discharge the patient, kenapa suddenly the LFT is so high? Korek, all of them were taking papaya leaf extract. And one was like, my mother gave to me, I tak sampai hati not to take. I said, no, please don't take. So, I mean, to be honest with you, there's no studies to show that it actually, prevents severe dengue, prevents bleeding or anything. The only thing that it showed is that the platelet recovery was a little bit quicker by 1 day. So the platelet's going to recover anyway. And the risk is that it might cause worsening transaminitis. So that's why we avoid it, because there's no benefit and it might cause harm.
I hope IMR has retracted their suggestion. Okay, thank you very much, Dr. Long. I think we'll have a 7-minute break and then come back here so that we can continue. You can take your drinks and tea and bring it into the room, and then we'll continue. Otherwise, we'll miss World Cup. on the initial management of dengue requiring hospitalization. Sure.
Okay, thanks again for that. So earlier, Dr. Ong talked to you about what to do in the outpatient setting. So now I'm going to move on to the group B and C. So these are people who will need to be referred to the hospital and will be hospitalized if they fulfill the criteria. Okay, so I'll start off a little bit with the case that Prof. Lucy had highlighted earlier. So this gentleman who presented on day 2 of illness to his GP, had a temperature of 40 degrees Celsius, vital signs were fairly stable, 140/88, heart rate of 110. Diagnosis of viral fever, but despite that, he was given antibiotics and also given Voltaren for presumably his body aches. So he came again on day 4, day 4 of illness. That is his second GP visit, where he now complained of vomiting, reduced appetite, and abdominal pain. BP, if you compare it to the first one, is much lower, 100/60. The GP suspected the patient was unwell, but patient said, no, I'm okay. I just need an MC. I just need some medication. But the GP insisted on doing some blood investigations. So this was at noon. At 3 p.m., the blood test came back, NS1 positive, IgM, IgG negative, hemoglobin 18 with a platelet of 11,000. And the GP quickly called him and referred him to the hospital. So, what should the GP do during the second visit at 12 noon at 12 July? Should the GP wait for full blood count and the dengue combo test before deciding whether to just send the patient home, come back later, or should be referred for admission? So this is what we hope to achieve, hope to answer after this talk. So a reminder of the classification of dengue. So people who have probable dengue, and then once they have probable dengue, you ask yourself whether there's severe dengue or not, if they are in the critical phase. And if they do not fulfill the criteria of severe dengue, you ask yourself whether they have warning signs. So this is the 2 groups that will require to be referred to the hospital for hospitalization if needed. So as mentioned earlier, the reason why the classification was changed, one of the reasons is to help us clinicians to differentiate between non-severe and severe dengue. Help us with the decision making about the intensity of treatment and observation, and this also includes whether to hospitalize the patient or whether to refer the patient for further care. So we've seen this before, the 5 steps before leading up to the management decision. What do we do with the patient? You've seen this before, Group A, Group B, Group C. So Group A was explained to you by Dr. Ong earlier on what to do if you decide that the patient fulfills the criteria for Group A and therefore can be managed in an outpatient setting. Group B and Group C are the ones that we'll be discussing a little bit today. People that you would need to consider admitting or referring for admission. So just a recap, who are the people who fulfill the criteria for Group A? Those who are okay, no warning signs, no real comorbids, and they are able to come back for daily review and also daily full blood count. So Group B are those who should be considered for admission, either because they are now in the critical phase and have warning signs, or they have comorbidities that would need closer observation, as they may be at higher risk of developing severe dengue, or those who live far from your practice. They can't come every day for repeat full blood count and also for re-evaluation. And Group Cs are those who have any of the features of severe dengue, and these are the people who need emergency referral for admission and further care. So what do you do with those who are in Group B? So these are some of the criteria for those who would fall into the Group B. Either they have comorbidities, or they have warning signs, or they have social circumstances that will not allow them to come back daily. So first and foremost, when they come to the hospital and they fulfill the criteria, they will be admitted for inpatient care. They will be monitored closely hemodynamically. They will have repeated full blood count to guide the interventions. They will have IV fluid, which will be used judiciously. And if they develop severe dengue or develop shock, they will have fluid resuscitation, and also for us to correct any metabolic acidosis, electrolytes if needed. What about group C? Group C are those who have severe dengue. So in this group of patients, the reason for referral, the reason that they need to come in immediately is we'll do everything that we've done in group B, plus, these patients are in shock. Most of them are in shock. So they will need a larger initial volume at a faster rate. We may need to consider using colloid instead of crystalloids. And if they are improving, then we will titrate the IV fluid slowly and off it at an appropriate time. And this is the group that are at high risk of developing bleeding, not just overt bleeding, but occult bleeding, bleeding that you can't see, but you highly suspect that is bleeding. Once again, to reiterate that prophylactic platelet transfusion is not indicated in this group or in any group. Okay, so one of the reasons to be admitted is because these patients may require IV fluid therapy. And there are a couple of reasons why you will need IV therapy, either for resuscitation therapy, rehydration, replacement, or maintenance. So in the point of view from a primary care setting, what can you do? When would you give IV fluids for your patients? Personally, I feel you will only need IV fluid in the primary care setting for resuscitation therapy. So it's very, very important to be able to pick up someone who is in dengue shock. So dengue shock is a hypovolemic shock. So when you are hypovolemic, you have to replace the intravascular volume that is depleted. So therefore, resuscitation therapy is the first thing that you will need to do if you have somebody who is in shock. Now, I know some places they have a patient, looks a little bit weak, they don't think they need to be referred to the hospital, they give 1 pint IV drip and then send them home. Strictly speaking, this should not be the case. We should not be managing it that way, because we've had one too many cases presenting to our mortality meeting where we found out that the patient either had 1 or 2 pints in the GP or 1 or 2 pints in the clinic kesihatan, sent home. Then when they go home, they're still vomiting away, they're still having diarrhea, they're still weak, or they live alone, they can't go and get their drink, they're not drinking. So they end up depleted again, right? So at the end of the day, if you feel this patient needs IV fluids, even if it's not for resuscitation, but just because they have warning signs, refer them on. Instead of giving 1 or 2 pints, to reassure yourself, reassure the patient, send them home, then the next thing you know, they are back in the ED in shock. We don't want that kind of thing. So to be safe, if you feel somebody needs fluid, it's time to refer, okay? So if you go to the CPG, if you go to the WHO training website talking about algorithm, how to treat somebody in group B or group C, there's a lot of nice algorithm in terms of how you would manage the IV fluid. It's very detailed, step by step, but I think that's probably more applicable if you're in the hospital to go through the whole thing. So here, I'm just going to concentrate on how you can use those algorithm in your primary care setting. So this is for group B dengue patients who have warning signs, but they are not in shock. So this is how you would start the IV fluid management. So instead of just gantong 1 pint, not really knowing how much, how fast you're giving it, this would give you a more, guided way of starting your IV fluid. So if possible, you should do a full blood count to get the hematocrit baseline before you start your IV therapy. This can be done in group B because, they're not in shock. It's not like a true emergency that you have to send them to the ED immediately. You still have a bit of time, right? So you can tell the patient, we're either going to get you an ambulance, or maybe the patient says, okay, I will call my family to come and pick me up and I'll go to the hospital. So you have a few hours, right? So instead of just not doing anything to the patient, you may want to consider sending the patient over to the hospital with some IV drip. So if you're going to do IV drip, then try to get a full blood count and give the results to the patient to take to the hospital with them. So that would be the hematocrit before you start your IV drip. So what do you give them? You can use crystalloid for this kind of patient. You know, your normal saline would be good enough, all right? And what rate? The rate is about 5 to 7 mils per kg. So you have an average adult, 50 to 60 years old. So you're looking at about 250 to 350, so about 1 pint, yeah? Over 1 to 2 hours. So you don't need to rush it in. Okay, for group B, you don't need to rush it in. So you just start the drip while waiting for the family to come or for the ambulance to come to bring the patient to the hospital. The key is, if the patient is still with you at the end of your drip of 1 to 2 hours, a reassessment must be done. So you've seen the patient before, you've done the BP, you've done the CCTVR. Now you're going to do it again after you've given your drip and you want to know what's going on, right? So just to remind you what CCTVR means, it's just picking up the hand, looking at the color, looking at the capillary fill time, temperature, volume of the pulse, and also the rate of the pulse rate. And then if you're able to see whether in that 1 hour, whether the patient actually went to the toilet, is there any urine that's coming out as well. So I'm not going to go down the whole algorithm because I think it's not very applicable for the outpatient setting. So if they do get admitted, this is what we will do. We will monitor them for 24, 48 hours, look for any signs of further plasma leakage, shock or bleeding. We do a detailed IO charting for the patient, so they are empowered to actually document how much they take in and also output. And we'll monitor them in terms of vital signs, hematocrit, sugar if needed, and also the electrolytes and other organ functions. So what about those who get admitted, but they do not have any warning signs, but they get admitted because they have comorbidities? So for these patients, in most of them, especially if they're unstable or uncontrolled or they have multiple comorbidities, they may need to be admitted early in the febrile phase. Even in the febrile phase, you don't need to wait for critical phase, so that we can monitor them closely, monitor their baseline hematocrit, and also other parameters like the sugar and the blood pressure. Okay, so the group B patients that do not have warning signs but get admitted, we don't necessarily start them on IV fluid. We just encourage orally and only start IV fluid if they need it on a maintenance or even lower, and as tolerated. Okay, so monitoring is as such. Okay, what about those who are in shock? So the patient comes to you in your clinic, you've done your vital signs assessment, CCTVR, and you feel that the patient is in shock. So shock can be divided into compensated or decompensated shock. So compensated shock is when the systolic pressure is still maintained, but there are signs of reduced perfusion. The CCTVR, prolonged capillary fill time, cold peripheries, pulse volume is low. So this patient is in shock. So what can you do in your GP setting or your primary care setting to help the patient while you're waiting for them to go to the hospital, while you're waiting for the ambulance to come? So same principle, you start the IV drip. Before you start the IV drip, if possible, try to get a full blood count. GXM may not be applicable to you, but you know, if you have a way of taking it, can send with the patient, you can do that as well. But to me, at the end of the day, if you can do a full blood count, that will be very, very useful. Okay. Then you start fluids. So what do you give the patient? So in a compensated shock, you can still use crystalloid. You don't need to go and find your colloids, or, you know, like a lot of hospitals are now using albumin. Don't worry about that. Just use your crystalloid, okay? The main thing is to get the fluid in, okay? How much do you give? If you remember in group B, we started off with about 5 cc per kg. Here, because they're in shock, so you want to give more. The minimum is 5 cc, but often we give 7 to 10 mils per kg for adults, and more for children, 10 to 20 mils per kg for children. And you give it over 1 hour. So earlier, there's no real rush, so you can give it like over 1 or 2 hours. But now it's shock, so you want to rush a little bit and give a little bit more volume, okay? So a higher volume, a little bit faster compared to group B. Once again, if the patient is still with you, once you finish that drip, reassess the patient, because then you need to decide whether you need to give more fluid or you really need to send the patient to the hospital ASAP if they're not already there, okay? So it's just like any other resuscitation lah, but just a little bit more focused when it comes to dengue. Okay, the other group C is those with decompensated or hypotensive shock. So these are the ones that BP has crashed, you could hardly feel the pulse, they may even be mottled, right? So very sick. So when they present to you like that, it didn't just happen in the last half an hour. They've probably been sitting at home, slowly from warning signs, compensated shock, and now they're in decompensated shock, okay? So it means that you have to be more vigorous in your management. So you cannot just call the ED, call the ambulance, wait for the ambulance to come. You really need to do something. Shock patients, you really need to do something. So once again, try to get a full blood count if you can. And at this point, you can still use your crystalloid. If you have colloid, okay, you can start the colloid, but if not, don't worry. You can still use your crystalloid. It's decompensated shock. So even bad, even worse than compensated shock. So it's logical to use more fluid. So just now we were talking about, 5 to 10 mils. Now we're really talking about higher, about 10 mils at least, sometimes up to 20 mils per kg for an adult, okay? And you have to give it fast. So earlier you were talking about 1 hour, now we're talking about 15 to 30 minutes. So basically you have to be by the patient, you set the drip, you run the fluid and stay by them. You cannot go and see another patient. You really have to stay by them until your ambulance comes, okay? So for adults, 10 to 20 mils per kg, can still use crystalloid. You can even use colloid if you have. It has to go in quickly, 15 to 30 minutes, okay? And then if the patient is still with you, you have to reassess. Reassess their hemodynamic status. Don't worry about doing another full blood count. Don't worry about checking what is the hematocrit now. You're in the outpatient setting, right? In your GP or in your clinic kesihatan. So basically focus on reassessing the hemodynamic status. If you still feel that the patient is in shock, just give more fluid because you won't have blood, kan? So just give more fluid and just rush that ambulance to come for the patient to go to the hospital ASAP. This is something that I think Selangor FMS came up with recently. So I hope most of you have seen this. So they have a nice algorithm, sort of a bit of a guidance on how to approach a patient right from the point that you suspect them until when to refer to the hospital and when to do resus and whatnot, okay? Okay, so I'm going to go through a case, basically. Hang on. Yeah, so sorry, that case that we were talking about just now. So remember the gentleman, he came in on day 4 of illness, and at that point he had vomiting, reduced appetite, abdominal pain, blood pressure was 100/60, which looks okay, but when you compare to day 1 or day 2, 140/88. We don't know what the pulse rate is. GP was already very worried, suspected the patient was unwell, but patient was like, no, I'm okay, but agreed to have his bloods taken. NS1 was positive, IgM, IgG negative, hemoglobin 18 and platelet 11,000. So if you are the GP, what should you do at 12 noon, at noon itself? What else do you think you can do for the patient? Sorry, I tak dengar. Yeah, exactly. So even at 12, you could have called the ambulance. Why? Why do you think you could have called at 12 o'clock? BP, right? BP is already low. What's missing from this documentation? How else could you assess the patient? Yes, CCTVR, right? CCTVR. That would give you a lot of clues. So you don't need to wait for your full blood count. You don't need to wait for your diagnostic test. Look at the patient clinically. Even if it is not dengue, a shock patient is a shock patient. You have to send them to the hospital ASAP. Okay? So call an ambulance even at 12 noon. You don't need to wait for 3 p.m. And call the ED physician if you think the patient is in shock. That would help a lot as well. Why do you think you should call the ED? You have lots of patients outside. Nak call ED lagi, nak locate them lagi. Not easy. Why would it be useful to call the ED department? Because it's a shock patient, kan? You really want to prepare them. And if you're going to send them to a big ED especially, they can get lost. If they just go there with a referral letter, they can get lost. Okay? I mean, if you go in the ambulance, maybe okay sikit lah, kan? But if you know that this patient only just went there with the wife, kan? So, and to make matters worse, he actually walked in, macho. He just walked in, thought he was still well. And, triage tengok dia walking. Okay lah. So let me tell you why you need to call the ED. So what actually happened, I mean, you've heard this from Policy before, kan? He actually went to ED, triage to the green zone. Second triage pun triage dia to the green zone juga. BP 110/78. Okay lah, kan? Right? Tak ada fever, 37.5. Triage is probably apalah GP ni pun nak hantar ke? Right? And if the referral, even if your referral letter wrote there HB 18, platelet 11,000, who's at the triage? They may not understand the gravity of this. Okay? So obviously the GP knew that the patient was unwell. Why do you think the ED triage person did not think so? Why do you think the ED kata okay lah? Yeah. So this is the first time they're seeing the patient, right? So if a macho guy comes in, walking, tolak isteri dia ke tepi, isteri nak bawa wheelchair pun tak nak, right? And then BP like that, okay? And then maybe the GP referral just wrote, referring to you for dengue, right? NS1 positive, platelet 11,000. If you don't write there, he has warning signs, he's in shock, it will be missed, okay? Okay, so what else could you do as a GP while you're waiting for the ambulance to come, if you were to call the ambulance? IV drip, right? So you can start the IV drip, then. So set a line, start free resuscitation. So if you think this is shock, you start at least 5 to 10 mils per kg while you're waiting for the ambulance. In fact, in this case, even if the wife insisted to bring him, you have to say, no, this is a shock. He has to go now with an ambulance because I'm going to start a drip. Okay? Oh, okay. So unfortunately, this patient died because, as you heard earlier, he was waiting in the green zone, lama sangat, went to another hospital, and when he reached the other hospital, he was already very, very sick lah. BP 100/75, tachycardic. They couldn't get a line in. He was cold, dusky. And despite giving him the fluid resuscitation and going to ICU, he died after just 2 days. Tengok given a transfuse 4 unit blood, FFP, cryoprecipitate, that's not going to help him. That initial bit is the one that's going to help him. Okay, thank you. Right, finish it.
Thank you, Dr. Sreshma. There are a few questions here. Again, all the patients died. Very depressing. Okay, is there
I know. We were talking about it.
Is there an authority or law to force to admit a dengue patient with warning sign who refused the referral despite counselling?
I don't think so, unless you say that he's a psychiatric case. That I don't think so.
All right. If I have to put patient in GP with warning sign, example vomiting 3 times, but still can tolerate orally, do we still give the 5 to 7 cc per kilo per hour, or can we just give the maintenance 1.2 to 1.5 cc per kilo per hour and encourage orally from the GP?
So this is what I'm saying. To be honest with you, I think one of the reasons GPs are not allowed to give IV drip, even klinik kesihatan, is because of this. They were seeing a lot of dengue mortalities when they go back. They saw some of the patients should have been sent to the hospital earlier, but the GP or even the patient pujuk the GP, tak apalah, you just start me on a drip and then I'll go home, you know. So to me, if your clinical decision, you say that this patient needs a drip, you should refer to the hospital. Don't risk it lah. Don't risk it.
What's that question on the management just now? It's gone.
The end-stage renal failure, heart failure, admit.
Oh, okay.
Don't play, admit.
This one,
even we
yeah,
don't know
this
how
one.
to. I mean,
This one.
we find
This
it
is a
difficult.
personal question, I think. I had a patient, day 3 of illness, dengue fever, entering critical phase. Came for repeat LBC today. Noted hematocrit increase from 46.3 to 47.8. Otherwise clinically stable. WBC 4, platelet 213, but I still referred patient as hematocrit increase. And I gave patient referral letter to the ED. Is this management right? The increase is just a few.
Yeah, the increase, strictly speaking, is 20%.
20%, yeah.
Strictly speaking lah, 20%. But I think what's more important, number one, is your clinical assessment. You see that clinically stable, right? That's your number one criteria. Because if you look at the warning signs, it's all clinical. Cuma satu je, rise in hematocrit with a drop in platelet. So it has to come together. First and foremost, it has to come together, not just hematocrit alone. And that hematocrit is not considered a rise, that's considered quite stable. Okay, so 20%, tapi janganlah 19%, tapi clinically you tak refer pula kan, alright? So your clinical assessment first, and then if on top of that your hematocrit pun naik by, even naik by 10% pun, if the clinical is already kaput, you will send. Okay, you will refer.
Okay, thank you, Sherpa.
Okay.
So we before we move to the next session, which is a very quick session on case presentations, I got a message here on my phone from a very senior pediatrician in Penang. It says Dr. Ong missed out the advice to patient to take dengue vaccine when patients are eventually discharged from outpatient. Okay, and he also said the CPG on dengue fever must include advice all dengue patients to take up dengue vaccine after recovery. So you guys do it. All right, now we move on to the final and very important, hopefully very important session, which are the case study presentations. And this will bring up real clinical scenarios that allow us to apply the principles that we've learned today, right? And for the first case, we'd like to invite Dr. Anjana Kukrija, who is a consultant infectious disease physician from UMMC, and she'll be presenting a case study on identifying dengue phases. So, yeah.
Thank you, Dato. Very good afternoon, everyone, and thank you for staying all the way to the end. Yes, my name is Anjana, and you've heard really excellent lectures on the clinical cause and management of dengue. And my role over the next 15 minutes is to simply put that knowledge into practice. So we will do 2 real-life cases, and then together decide which phase of dengue the patient is in, okay? As we go through the cases, I'd like to think as if this is really happening in your own clinic or in your own setting. So I only have 15 minutes, so I'll go through this pretty fast. So we'll meet the first patient, Mr. Ahmad. So this is how he looks like, a cartoon version of him. Today is day 2 of illness. So he presented, well, yesterday with fever. So it's very important to always document your onset date as well, so you can calculate your day of illness. He's feeling miserable, he's got myalgia, he's not really eating his food, but he's drinking very well, and he's passing urine about 5 times a day. There's no other GI losses, no sore throat, no UTI symptoms, no URTI symptoms. So when we examine him, his blood pressure is okay, 128/68. His heart rate is about 94, and his febrile 40. Right? His CCR-TV is good. His throat is not injected. There's no cervical lymph nodes. His lungs are clear, and abdomen is fine. So at this time, He just basically has acute undifferentiated febrile illness. But given where we are at, we have to make sure that this is not dengue, right? So we do together we do a dengue rapid combo test as well as a full blood count. And you can see his NS1 is detected. And so his HB is quite stable, hematocrit is 38. This is day 2 of illness. So his white cell is still normal, platelets still normal, but he's already lymphopenic as we expect in this phase of dengue. So what would your diagnosis be? I hope the Slido works. No, it's not working. It's not working. Yeah. Yeah, it's not working. Tak jalan eh? Yeah, normally it should load with the QR code. Yeah. Okay, never mind. What's your diagnosis? Okay, so full diagnosis would be confirmed dengue fever, right? Your NS1 is detected. Day 2 of illness in febrile phase. Okay, so that's it. Okay, there's no warning sign punya cerita when somebody is in febrile phase. Okay, so you tell him he has got dengue, all right? You give him this home monitoring card as Ong shared earlier, and then you prescribe the fluids. You tell him how much he needs to drink. You arrange an appointment to see him again. Okay, so I'm going to fast forward a bit until his day 5 of illness. So now he's actually feeling better. He's got no more body aches. He tells you he did no fever today. The Panadol that he was prescribed, he took it 2 days ago. He's able to drink 2 to 3 liters a day, but still not finishing his portion of his rice. Loose stools, 1 episode yesterday, today dah tak ada dah. No abdominal pain, no bleeding tendencies. So you examine him, he actually looks a bit better, compared to the first day, more cheerful. His lungs are clear and his abdomen is soft and non-tender. So you had your dengue monitoring card, which you had given him on day 1, and every day he's been coming to your clinic. So you can see now, this is today, I mean, this is like in the future, okay, sorry. So day 2, day 3, day 4, day 5, you can see that he was febrile the first 3 days, seems to have no fever today, and his last PCM was 2 days ago. BP and all is stable. You can see the heart rate is actually improving as he's become less febrile. Hemoglobin and hematocrit are stable. You can see his white cell continues to drop. His platelets continues to drop. So at this juncture, what is he in? What phase is he in? Critical phase. So he's confirmed dengue fever, day 5 of illness, in critical phase without any warning signs, okay? Because he doesn't have any warning signs. So, okay, so remember Prof. Lucy's slide? Usually, in day 5, that's when their temperature settles, their white cell drops, their platelet drops. Okay, so this is the part that we need to monitor them a bit closer. So he sent home with this time, he was given more education regarding the warning signs, okay? So in case any of these things happen, he needs to go stat to the nearest hospital or come back. And then he has a TCA anyway for the next day. So he continues to come back, and finally on day 7, he's so much better already, can already makan, minum, and he's complaining of a lot of itchiness over his hands and his limbs. And this is the rash that you see. Otherwise, clinically, he's comfortable, his CCR-TV is good, his lungs are clear, his abdomen soft, no ascites. You check his FBC again, you can see everything is nicely recovering, white cell is improving, platelet is improving. So now he's in recovery phase, right? But, so this is successful, simple case. But life is not always so straightforward, right? So the next case that I'm going to bring you through is really to help you identify when critical phase is. As sometimes Prof. Sharifah said, we will say it's today, then after that, fever or not, effervescence or not. So we will, hopefully the next case teachers can give us some teaching points on that. So this is a real case. I just discharged this boy a few days ago. He's 19 years old. He's a state volleyball player, and he's a non-smoker. He doesn't vape. So he's a student staying in a hostel, not in KL, in Seremban. And he came in actually on day 2 of illness with myalgia, arthralgia. He had vomiting on the first day of illness. He's not eating, but he's drinking very, very well. He has good urine output. The friends in the hostel also got dengue, so his parents brought him back from the hostel back here, okay? So he took Panadol an hour before coming to ED. So when we examine him, his blood pressure is 106/69. So he's a lean kind of boy, right? He's very fit. His heart rate is 88. His temperature was 37.8. He was flushed. He was tired, but his CCRTV was good. He was warm to touch. Lungs and abdomen, no signs of effusion. So because of the history of his friends who kena dengue, ED did NS1, and you can see his NS1 is detected, and this was his full blood count on the second day. So very, very normal, just lymphopenia, very in keeping with second day of fever. But sadly, so now your diagnosis would be confirmed dengue fever, day 2 of illness in febrile phase. So notice, I know his temperature was 37.8, but remember he took paracetamol an hour before coming. So, instead of, we don't rely on one reading, you need to put the whole picture together, his day of illness, his symptoms, his examination, and his investigations. So sadly, somebody thought he was in critical febrile phase with warning signs or something like critical phase with warning signs at day 2, and he got admitted to the ward for that, okay? So just remember, the same symptom may have different clinical significance on the day of illness. So when someone is vomiting on day 1, day 2, this is probably because they're so viremic, they feel so ill because of that. But if they're vomiting at day 4, day 5, then you're worried, is this a warning sign? So the same symptom, different day, you need to take a step back and see the whole picture. So this boy was admitted on day 2, nothing like day 2 to day 5, he just fever every day. And I fast forward to day 6. So on day 6, he was still having fever. So this is the time that, I start wondering, why is he still having fever? It's already day 6. But he's feeling better. He's actually sitting up. He says his body aches are less, no abdominal pain, no GI losses. He's walking around in his room, very good oral intake. So this is his chart. So you can see his blood pressure is pretty stable. There's no narrowing of pulse pressure. He's not tachycardic. He's about 79 to 80, 70 to 80. But he's still having fever, right? So morning it was like 38.3, 38.8. Then in the afternoon, it came down a bit. And then at night, it was 39.3. So remember, he's a volleyball player. So I think his resting heart rate as it is probably low. So even 39, 70 for him is in keeping with like the extra 10 that we add for every 1 degree of fever. So I was looking at this and like, what phase is he in now? What do you think? Is he still febrile? Is he critical? Yes. So Prof. Sharifah asked the right question. What is his full blood count? So I'll go back to the patient first, okay? I haven't given you the examination. So I go back to him. He's very well. He's sitting down chatting. CCRTV is good. He's drinking so much, about 2.7 liters. He was passing a lot of urine, so I did a couple of sugar checks just to make sure that large volume of urine output is not related to a high sugar. It was just that he was drinking a lot. So then we looked at his full blood count. So because he was with us every day, right? So every day the poor boy was poked. So you can see I've put in his temperature here as well, so you can see. Yeah, every day. Yeah, so day 5, okay, day 2, day 3, day 4 was once a day. Then day 5, because we were like, is he critical, not critical? He had a few bloods. And then poor boy was poked 3 times on the 12th of July. So you can see his white cell is starting to drop here. And his platelets are also starting to drop here. So when I saw him, I took that 38 temperature as his critical phase. Then that was when I first saw him in the morning. And then the next, so I took 12th of July as his first day of critical phase, okay? So let's see if I was right or not, okay? So the next day, he's still fevering, okay? He's still fevering, but he's drinking very well. No warning signs, comfortable, CCR-TV is good. See, his IO chart is so positive. I mean, so much he's drinking 3.2 liters. So I look back at his temperature chart. So again, BP looks good. There's no narrowing of pulse pressure. He had a spike at 8 that morning when I saw him. And then it kind of came down a little bit to 38, 31, but still, 38.3, 38.4. So when the fever goes beyond 72 hours, there's a few things you need to ask yourself. So this is Prof. Lucy's slide really summarizes dengue very nicely, but there are a few things you need to ask yourself. 1, is it still febrile phase? Because febrile phase can last 3 to 7 days. 2, is there a secondary infection? Especially somebody who is in the ward, thrombophlebitis is sadly much more common than we expect. And then third, could this just be a saddleback fever? Because you see, the fever did come down to 38 and then went back up. So could this just be a saddleback fever? So he is in critical phase and it's saddlebacking. Or very rarely, if someone is persistently having fever, one thing we can consider is HLH. But in HLH, the patient generally looks sick, there's worsening liver enzymes, you know, the cytopenias are more persistent, and there's high ferritin and all that. So I went back to the patient. I asked myself all of this and I went back to him. So there was no thrombophlebitis, but he said the IV cannula was painful. He was drinking so well, so we took it off. He doesn't really need it anyway. But he didn't have any new URTI symptoms, no UTI symptoms. He was just fine, sitting down there chilling. So we looked at his bloods. And you can see on day 7, his white cell, I guess, kind of improving, but his platelets are continuing to drop. So I was very confident that he was still in critical phase, meaning the day that I had taken the day before when the platelets first started to drop, I had taken here as the critical phase around, like, I had taken 8 a.m. We were contemplating to switch to like 7 p.m., but I was confident that day 1, day 2 of critical. So we continued to monitor him. I thought the fever was probably saddleback, but I took off the cannula anyway. And the next day, he's saying very itchy rash on his hands. This is really him, okay? This is a real story. But he was so much better. He was just very itchy. And then I looked at his counts, and thankfully, you can see that his fever had finally resolved on its own. And then we looked at his counts, and it was improving already by day 8. The reason we kept him another day was because when I saw him on day 8, it was the first time I'm seeing him without fever. So I wanted to make sure 24 hours he had no fever before sending him home. So we happened to have 15 July punya bloods as well. So everything continued to improve, and he was discharged well. But the main thing I wanted to show here is that, you know, after about 72 hours of illness, at day 3, day 4 of illness, whenever you see the patient, you need to ask yourself, is he entering that critical phase? So when the white cell count is falling, your platelets are approaching below 100, you really need to think that this could be critical phase, even though the patient is having a fever. So my take-home message, I hope I did it within 15 minutes, is that always assess the patient systematically, right? Take a step back, integrate the day of illness, their history, the examination findings, and the laboratory trends. Again, after 72 hours, ask yourself, white cell dropping, platelet dropping, definitely in critical phase already, okay? And then, but don't forget, if they're having fever beyond 72 hours, look for other sources of fever as well, before just just blaming it on saddleback or just saying this fellow is still in febrile phase. And if you identify the phase correctly, then the management becomes much, much simpler and much more accurate. So thank you. That is all.
Thank you. Thank you, Dr. Anjana. Thanks for sharing patients that survive. There is a question here. Does it mean it's unlikely for a patient to have warning sign during the febrile phase?
Yeah, it's very unlikely to have warning sign during the febrile phase. Yeah.
I've got a question. Why is it called critical phase?
It's called critical phase because that's the phase that the patient is most leaky. So that's the time that they can actually have the plasma leakage. So it's critical for us to monitor them closely to make sure that they don't enter plasma leakage. That's how I've kind of understood it.
That's the phase of defervescence, is it?
Yeah, so defervescence, I mean, we always use critical and defervescence interchangeably, but I think we need to understand that defervescence just means the fever has settled. And that is one component of critical phase. Doesn't mean that it is just, yeah.
All right, thank you.
Yeah.
It's frightening when you call it critical. Thank you. Okay, the next talk will be Dr. Lim Ka Chuan, who's a consultant infectious disease physician from Hospital Serdang, and he's going to be presenting a case study on difficulties in diagnosis. Dr. Lim?
Thank you.
Is it okay I walk around? Thanks. I think everyone is tired. I think I want to walk around. So my talk will complement what Prof. Sharifah have presented. So initially, when I was being approached, I was thinking I need to do 5-6 cases. Then suddenly I realized I only have 50 minutes. So I just wasted 30 seconds to introduce. Okay, so I have a patient here, 26 years old lady, primi gravida, 20 weeks, okay, 20 weeks pregnancy. We treated GP on day 2 of illness and was discharged as viral AGE. Very common, right? AGE is one of the commonest presentation to GP. So, but she came, this is a real life case, she came to my emergency department on day 5 illness. Other than the pre-existing symptom of fever, headache, myalgia, diarrhea, now she had new onset vomiting on day 5 of illness. And these are the warning signs. Stable or unstable patients? Unstable because of? Heart rate, heart rate, tachycardic, right? And are you surprised that we are in a dengue talk, right? So are you surprised to have a vomiting on the day 5 illness? What does it mean to you? Warning sign. So warning sign. So vomiting on day 1 might be due to a viremia, especially when the platelet is still high. Okay, that's not a warning sign. In the new dengue 3PG, they will specify that. But in the critical period, day 4, day 5, new onset of vomiting is a warning sign. Okay, so that's how you differentiate it. Then you did a FBC, POCT, white cell is low, neutrophil is not high, platelet is low. Dengue combo, unfortunately, negative. Why? Why negative? Anyone?
Viral load.
Viral load, okay? So the level of virus in your blood. Okay, so just now someone mentioned about window period, right? So your NS1 is best detected between day 3 to day 5, right? So it will reduce. Your IgM will start in primary dengue, will start between day 5 to day 7. So you have a gap there. You have a gap there where everything could be negative. So can you say this is not dengue now? Cannot, not because you are in dengue course. Bila balik pun jaga cannot. Okay, but no, it's not because you follow me or follow the lecturers here, the speakers here, because you follow guidelines. Okay. For those going for exam, because you follow guidelines, bukan you datang dengar lecture hari ini. So what the guidelines say? This WHO guidelines say, how do you define probable dengue? When you have fever plus 2 or more criteria. So here, patient has vomiting, patient has myalgia, patient has leukopenia. Okay, so if you have confirmed dengue, of course you can have lab confirmed, but then in this case, unfortunately, your NS1, IgM, IgG, all 3 are negative. Okay, so if I were the emergency physician there, I would be cursing the GP day 2 why tak buat dengue combo, but never mind, because you probably will have picked up dengue at that time. Okay, so this is it. So you can't rule out. So before that, so what would you do? You can't rule out dengue, but you don't have a confirmed dengue. Yes.
Can send repeat test or send bloods to lab.
Okay, you want to send a formal test to lab. ELISA could be more sensitive than your POCT test, correct? Anything else? But the lab is middle 12 a.m. Your lab will run tomorrow morning. We don't want to help you. Anyone else? Want to try? Go on. Anyone else? The unstable patient, right? You need to manage at the ED itself, right? You can't say, wait for the lab to come back, right? So what will you do at this point? Imagine yourself 12 a.m. at the ED seeing this patient. Call ONG, okay. ONG akan suruh call medical. Medical suruh call ID. Call ID suruh call ICU. Okay, no. So at that point, there are 2 things you need to do. You manage the drip as per dengue. You can't rule out dengue. So your drip management is as per dengue. So this is dengue probably in the compensated shock. I didn't give you more information, but possibly in compensated shock. But at the same time, you need to consider differential diagnosis. So what are the dengue mimics? Anyone? Leptospirosis. Anything else? Sorry? Other viral fevers, correct? Anything else? So viral fever, lepto? Malaria, yes? Chikungunya, very good. So how do you all differentiate all this? Okay, for the interest of time, okay, I prepared, this list is not an exhaustive list. These are the common differentials, but I listed down some differential symptoms. But do remember that these symptoms overlap, okay? You can't really rule out dengue for sure. For example, the first one are your respiratory viruses like your influenza, your adenovirus, your COVID, okay? But then they have predominant URTI symptoms like rhinitis, cough, sick contact, but don't use this to rule out dengue. Okay, you need to consider differential. You can send your recipe virus antigen panel, things like that, or your multiplex. But then, just to share a case, they can coexist. Actually, I just discharged one elderly Chinese auntie last month. She came to us on day 2 of illness. Platelet is 150 to 160, not low. There's no sign of leaking, bleeding, and NS1 positive. But she is having type 1 respiratory failure. Okay? Then people start to treat this is leaking. Start to treat. The chest X-ray is actually bilateral interstitial infiltrate. Okay? Then actually we did a dengue, we did a respi antigen, turned out to be influenza B. Turned out to be influenza B, but actually, when they refer to ID, we just ask one question. Is there any sick contact? Her daughter just recovered from influenza last week. So sometimes the details is in the devil, what is it called? The devil lies within the details. Okay, yeah, correct. Okay, fine. So you need to get a correct history. So these are a few clues. They can coexist. And chikungunya, one of the differentiating factors, they have very bad joint pain. The joint pain in dengue is arthralgia. They have joint pain but not swollen. Okay, if you have a swollen arthritis, especially symmetrical arthritis of the small hand, then you need to consider chikungunya. I think recently in Pejia, one of the kampong had a case, I think. Then lepto, of course. There's urban lepto and this classical lepto that you know, water activity, jungle activity. Of course, you try to get the travel history. But then the urban lepto is much more difficult to diagnose, okay? A few differentiating factors, they tend more common to have conjunctiva suffusion, calf tenderness. They tend to have jaundice, hyperbilirubinemia, then they might have AKI. We usually don't see AKI so common even in a severe dengue, okay? Then of course, malaria, never miss malaria. Recently, I have a Rohingya patients, IgM positive dengue, so treated as probable dengue, admitted to the ward. BFMP was sent and turned out to be malaria, okay? So you still treat the drip as per dengue, but then you need to consider your differentials. Okay, this is very important. Okay, a few more measles, your classical head to downwards rash, that will be later. And another common differential is sepsis. Now currently in my ICU, there's one young gentleman, okay, 5 minutes left, okay, can. Young gentleman who are day 1 in shock, BP low, requiring inotropic support. But it is a white pulse pressure hypotension. There's neutrophilia. CRP was 200. Platelet is still 170. NS1 positive. NS1 positive. So is the patient ill because of dengue? No, he's not in shock because of dengue. He's shocked because of the concomitant bacterial sepsis. Okay? So these are the few differentials that you need to consider. Unfortunately, when I prepared this slide, and just 2 days ago on Friday, 4 p.m., my surgeon called me. He accepted a case from a private center, perforated appendix. He was admitted to private center for 3 days, NS1 positive, treated as dengue. Warning sign was abdominal pain. So they treated as abdominal pain, warning sign. Then finally, they realized something is wrong. They did a CT. It's a perforated appendix. Okay, so these are so your differential should be very broad. Okay, it can come together with dengue or without dengue. So your differential must be broad because dengue symptoms are quite non-specific. Okay, so this patient does not have all these symptom signs, whatever. So I only have 5 minutes, so I need to be quick. So we treated as probable dengue, admitted to our ICU, treated as compensated shock in special population. She successfully responded to fluid therapy. Then we monitor the serial FBC. When you don't have your dengue combo to guide you, the next best thing to diagnose dengue is your serial FBC. Okay, so they show progressive downward trend of the white cell and platelet. Then we repeated the dengue combo 3 days later, shows serial conversion of the IgG. Okay, so this is primary dengue or secondary dengue? Secondary dengue. This is likely secondary dengue. Okay. Then we sent a molecular test which came back 1 week later from Myanmar, which is detected then too. I think this was a year or two ago for this case. Now the circulating strain is then 3. Huh? So take home message number 1, you must check your dengue combo test as early as possible. Don't check it when during the window period. Okay. Then you might be negative, then you might stuck, don't know this is dengue, not dengue, dengue, not dengue. Okay. So check as early as possible. So the rules that last time said must fever day 3, day 4, baru check dengue is no longer true. Okay. Then in fact, I would advise to check FBC even on day 1, day 2. It's not to diagnose or exclude dengue, but to help you to have better idea what is the baseline hematocrit. I have another morbidity case, not mortality case. Patient survived. Patient came in, a female came in with syncope, confirmed dengue. Okay, hematocrit was 40. Everyone is happy with the hematocrit 40. Okay, but lactate was 2 to 3. Okay, actually, her baseline, luckily for her, she had a baseline hematocrit, early FBC done on day 2 of illness, hematocrit of 30. Okay, if we were without this information, we would think that 40 is okay for a young female, right? So that's how important the early FBC and early dengue combo is. Okay, so this is just to highlight why I say secondary. So in primary, has been explained. So in primary, you have your antigenemia, then follow your IgM, followed by your IgG. In the secondary infection, which is on the right side, your NS1 antigenemia is shorter compared to primary, so you might get negative NS1 earlier. And the first one who rise actually is IgG. Your IgG might become positive even before your IgM. And your IgM, in fact, the white bar is your secondary dengue, black bar is your primary dengue. Your secondary dengue IgM positive rate is much lower compared to your primary dengue. Then this is the IgG. So this is your IgG where you should, okay, let me orientate. X-axis is the title of the test. Y-axis number of patients, somehow is done as such, but then this is negative. If the most left bar is negative, black is primary, white is secondary dengue. So as you can see, majority are negative on the date when it's less than day 3 of illness. In between day 4, 7 is like window period, neither here or there. If you more than day 7 illness, your primary dengue have low IgG titer, and in fact, your secondary dengue will have IgG titer higher than 320 and above. So therefore, this will help you to understand this table better, that this is from WHO guideline where if you have confirmed dengue, if you have dengue PCR positive or NS1 positive, or you documented seroconversion. But then if you have the positive IgM will be probable dengue. And this is why you must wonder why high IgG level. So this the table explains why high IgG level. Because if low IgG level, it will be just maybe your previous infection. If high IgG level will signifying secondary dengue. Okay? Because they goes up much higher and much faster here. Sorry. This one. They go up much higher, much faster. Okay? So I think I'm gonna skip that. In diagnostic dilemma, serial ABC is most helpful. And in this one, the PAHO paper, they have all 3 dengue, chikungunya, Zika there. So they did a study to see what can differentiate them well with high certainty. So if you, the one green, the one highlighted in green is the one in high certainty, is your progressive thrombocytopenia, leukopenia, and hemoconcentration. That's the best marker to differentiate dengue from other viruses. Okay. So these are the evaluation. I skip this. So summary, if you don't remember anything, check your dengue combo early. Don't wait until day 4, day 5, day 6. Okay. If you don't have the clue, you still can't rule out dengue. Serial FBC is your most useful friend. So hopefully with this Observation is limited by comprehension. True diagnostic insight requires foundation of prior knowledge. So we hopefully with this knowledge, help you to make the dengue diagnosis better. With that, thank you.
Thank you, Excellent. There are two questions here. This is in relation to that IgG.
Yeah.
So the first one is, why was it secondary dengue? As the first dengue combo was IgG negative and now it's zero conversion. And then the other one is related to it also. If IgG positive, NS1 and IgM negative, how to tell this is secondary dengue or past dengue infection?
Okay, so IgM might be negative in secondary dengue because of the hyperimmune response of the IgG, suppressing the IgM. So you might only get IgG positive in secondary dengue. Usually in primary dengue, you will see the IgM positive first, then followed by IgG. So this case is likely to be secondary dengue. So how to differentiate the IgG is by the titer. Hopefully, if you can do an ELISA test, your lab should be able to tell you this is high titer positive or low titer positive. But sometimes the DCT dengue combo test won't be able to really tell you. Sometimes we still resort to probable dengue and see the serial FBC trend. Yeah.
If NS1, IgM, IgG all positive, how do you classify this?
I look back at the day of illness.
Okay.
Yeah, so if everything positive, if it's very late, they test. Definitely dengue lah. But no diagnostic challenge. If NS1 positive, no question lah, it's dengue lah. Tapi whether you want to classify as primary or secondary, this one a bit susah lah. Usually. Yeah.
The combo test is calibrated to capture secondary dengue. If the IgG is positive, they set it at very high level before it becomes positive. Negative doesn't mean it's not there. It could be there, but it's not high enough to be positive.
I think we shouldn't be too worried about whether this is primary or secondary. At the end of the day, just treat your patient based on your clinical situation. We tend to have some cases where they see the IgG positive, oh, this is secondary, I have to give more fluid, I have to give this, give that. So we shouldn't be doing it that way. So if you think this is secondary, okay, maybe this patient is at risk of more severe disease, more monitoring, that's fine. But if you end up being so obsessed about whether this is primary and secondary because you want to do your fluids accordingly, that's a wrong way to do it.
Yeah, fluid therapy does not depend whether it's primary or secondary dengue. It's just for your knowledge.
Right. Thank you very much, Dr. Lim.
Actually, most secondary dengue infections are asymptomatic. All right. Most severe dengue are secondary infections, but most secondary dengue infections are asymptomatic. Okay, so hope you kind of understand.
Okay, right, we'll just move. We just got two more cases, all right? Lucy is going to present on patients with warning signs.
So I'll try and go this. So I'll just share with you some cases. So this is actually case one, not case two. So this is a 54-year-old female who presented at KK, first KK, huh? So she had onset of fever on 16th of February, and on the 17th, on day 2, she walked to the KK, first KK. And by that time, fever was 2 days with decreased oral intake. She had myalgia, no vomiting, no abdominal pain, no warning signs. And you can see she's febrile, but otherwise fairly normal, expected. So she was given paracetamol and then told to get a CBC the next morning, which would be day 3. So on day 3, she went back to the same KK. And this time she had dizziness, headache, decreased oral intake, She had no URTI symptoms. The doctors asked, got vomiting, tak ada, got diarrhea, tak ada, abdominal pain, tak ada, no chest pain, no myalgia. So temperatures coming down. She had still got stable blood pressure, good pulse volume, kept refill less than 2 seconds. They did a CBC and an NS1 was positive, and as you can see, the platelets 132, and the white cell is 3.1, and the hematocrit was 39.6. So they treated her as dengue, paracetamol, continued, notified as dengue, gave her the dengue card, and advised her to seek medical help if worsened symptoms and to repeat CBC the next morning. So what happened the next morning was she went in the late afternoon, but not to the same KK, to a different KK. So again, she had less oral intake, nausea, the doctors asked, got vomiting, tak ada, abdominal pain, tak ada, no URTI, no bleeding. So she was paying good hydration, warm extremities, kept refill less than 2 seconds, good pulse volume. Otherwise, no abnormalities, but blood, note the temperature is 36.2, white cell 2.9, platelets 88. So they diagnosed her as dengue fever, day 4 in effervescence, no warning signs, encouraged oral intake, and advised to go to the nearest hospital and to repeat CBC next day. So according to guidelines, sorry. So you can see the timelines, and she had fever onset, and she had fever on day 2, no warning signs, and day 3, no warning signs, but decreased oral intake throughout the whole period without any warning signs. But you can see the trend, the temperature's coming down. She's still got good perfusion. Hematocrit is fairly stable. The platelets are trending down, as you would expect. And she had no warning signs, so they encourage oral intake, right? But she had less oral intake, all right? So there's a disconnect. So on day 5, she was brought to another KK, this time with her daughter, and severe headache, dizziness. She hasn't been taking anything for the past 2 days. She was extremely lethargic looking, severely dehydrated, coated tongue, dry lips, no petechiae. Temperature is now no more there. She is tachycardic, small pulse volume, kept refill more than 2 seconds, and white cells 2.6, platelets have dropped further. Hematocrit has gone up from 39 to 46. So this time they would diagnose her with dengue, with dehydration and shock, and then managed with 500 mils of normal saline and referred to the nearest hospital. So we look at the timelines, in total, you can see that she's been going to the hospital every day, daily follow-up, from early febrile phase, and she didn't have any warning signs at all, and yet she developed shock. Can you do any better? She's done all she can. She followed the advice to the very letter, but still she developed shock, and actually this patient died. That's why we got hold of this kind of history. So how can we avoid this kind of outcome? All right, so I think the lesson, so after 4 days, 5 days, she is dizziness, she is not eating, and finally developed shock. So I think the lessons learned from this case is that we need to draw timelines. Okay, we cannot see patient one day, cross-section, without the trending. So understand the cumulative effects of an illness. You got to plot the trajectory as opposed to seeing the patients in silo. So cumulative effect of poor oral intake, progressive dehydration, starvation, not eating. So how do we get around this problem? Just ask the 3 golden questions. Are you eating? You drinking? Are you peeing? What are you doing? You can add up all these problems. And very important, after 72 hours, when the temperature is normal, anyone with reduced oral intake, don't advise oral intake anymore. Okay? They are past that period already. They have to be admitted for IV rehydration and then reassessed whether they can drink or not after the IV rehydration. All right, so now where is this dehydration coming from? She had no vomiting, no diarrhea, and yet how could she be dehydrated? So I want you to understand this term, okay? Insensible water loss. This is a passive process. You are completely unaware of this process, but takes place. As long as you are alive, it takes place. Okay, the primary function of this insensible water loss is thermoregulation, because we are heat producing engines, all right, and we need to dissipate heat, and if possible without the sweat gland involvement. And this is true insensible water loss through the skin, and therefore the body surface area is very important. And on average, it is about per meter square is about 300 to 500 mils per meter square. So on average in an adult is about 600 to 900 mils. And most of this is through the lungs and through the skin. Now, just not drinking enough fluid can lead to a fluid deficit, right? And if the patient has got fever, like he was, everything is just cumulative, all right? So by day 4, day 5, they are very, very dry. So just to quickly go through with you, say it's an adult patient who is 173, weighs 80 kilograms. The body surface area is about 2 square meters. And if we take daily insensible water loss as 400 per meter square, then he's losing about 800 per day. And then if he has got fever, then you add on some more, and he's another 400. And if you take if no diarrhea vomiting, the water loss is 1.2 liters, okay, which is about 1.5% of the person's body weight. Okay, so that is already, he's getting his physiological performance is not so good already. So after 3 days of fever with reduced oral intake, even if there's no diarrhea, no vomiting, your cumulative water losses is about 4.5. And that's why you see the CRO guidelines. They say that by the time they come in on day 4, day 5, you have to give them maintenance fluid plus a 5% deficit. All right, so that 5% deficit comes from this insensible water loss. All right, okay? So I hope that helps you to understand why even without diarrhea and vomiting, they are already incurring water loss. Now, a second case is the 6-year-old boy presented to the hospital on after 2 days fever and abdominal pain for 2 days. So the history was that he's been having fever for 2 days, went to the GP, went to the KK, the temperature was 38.5 and then referred to the hospital. And the story was the abdominal pain has been there for 2 days, started together with a fever, generalized abdominal pain, dull, sudden onset, on and off, 5 episodes a day, about 10 minutes each episode, with no exacerbation or relieving factor or radiation. There has been vomiting, about 1 episode, and non-projectile, no blood, generalized body ache, lethargy, and he's been taking about 2 cups of water every day with small amount of porridge, no diarrhea, no bleeding, no respiratory symptoms, and there has been fogging in the area 2 days ago. So on examination, he was febrile, blood pressure normal, tachycardic, breathing a little bit fast, saturating 99, alert, obeying commands, lethargic, cool extremities, cap refill 3 to 4 seconds, good pulse volume, dry coated tongue, no recession, no rash, no pedal edema. System examination was fairly normal, and the summary was this 6-year-old boy, recent fogging in a housing area, chief complaint of fever, abdominal pain for 2 days, 1 episode of vomiting, lethargy, body ache, lethargic, febrile, tachycardic, tachypneic, dehydrated. So the provisional diagnosis was day 2 of fever, dengue, febrile phase, warning signs of abdominal pain and lethargy, and incompensated shock. Okay, so my question to you is, do you agree with this evaluation? All right, so I see some of you responding. So just to because time is short, just to show you, NS1 is positive, and IgG, IgM negative. The platelets you can see is 225. Okay, so do you agree with the evaluation that this person, day 2 of fever, dengue fever, day 2, confirmed dengue, right? Confirmed day 2, you're looking at the platelet count? Yeah, So what about the warning signs? Abdominal pain, shock, and all that. Do you agree with that? So let's see, the abdominal pain, is this a warning sign? So his abdominal pain is fever pain for 2 days. So it means that it started on first day and second day. It's generalized abdominal pain, dull, sudden onset, on and off, 5 episodes, 10 minutes each episode. No exacerbation at all. Okay. Now, what about the abdominal pain in dengue shock? All right. So it is on day 4 onwards, during the critical period. By this time, the patient is afebrile and the pain is severe and persistent. All right. And it will not go away. All right. What would relieve the pain? It is fluid resuscitation. When you resuscitate adequately, the patient will tell you straight off, Doctor, sakit tak ada already. All right. So what is the mechanism behind these two types of abdominal pain? So in this patient, when the pain starts early and is on and off, it's a colicky abdominal pain. And the patient is constipated because he's not drinking, he's not eating, so he's constipated, so which means that he's actually dehydrated. All right. Whereas the abdominal pain in dengue shock is a result of autoregulation, splenic vasoconstriction, and the pain will not go away. All right. Now, what about the shock? Okay, so holding the patient's hand in the dengue shock patient, what you will get is, yes, the capillary refill will be more than 2 seconds. In the febrile patient, during the febrile phase, it's more than 2 seconds. The extremities will be cold in both cases, but the pulse volume in a dengue shock is a weak pulse volume. Whereas in the febrile phase, the pulse volume is still quite good. Both patients are tachycardic. So that is where, sometimes they get a little bit confused. So that's why I said when you do the CCTVR, make sure that you go through all the 5 parameters. And if the pulse volume is good, then think about it. It is unlikely that this is dengue shock. So what is the physiology behind this? In dengue shock, is a shutdown. It's a peripheral shutdown of the shutdown of the peripheral circulation to preserve blood to the vital organs in the hypovolemic patient. Now, in the febrile phase, that the shutting down, but preserving a good pulse volume is a thermoregulatory function in order to increase the body temperature to the reset thermostat in the hypothalamus. And the way the skin does it is to just bypass. Okay? So there is an arteriovenous anastomosis underneath in our dermal layer that will bypass. So you don't go to the capillaries. There's no blood going to the capillaries, so you can conserve your heat, get your body temperature up. All right, so there's 2 different phases. So coming back to the boy, so his provisional diagnosis is he's definitely day 2 of fever. He's definitely in the febrile phase. Doesn't have warnings. His abdominal pain is not a warning sign. He's not in shock. What he is dehydration. So his management, you would have to manage him, not as a shock case, but as a dehydrated patient. All right? Okay, so I hope that that helps to kind of differentiate some of the warning signs that are quite confusing if you just look at pain, okay, on its own. All right? Okay.
Thank you. Thank you, Steve. One question here. One question, Lucy. Does it mean that it is impossible for the patient to develop warning sign or shock during febrile phase?
So I think when we see febrile phase, we are looking at fever, okay? When you look at the evolution, fever is only one part of it. And like you said, there are many other factors contributing to it. It's a very inflammatory phase at that point. So the fever might still be there. So I would say, in order to know whether you have actually into the critical phase, is to look at your platelet count. Your platelet count will not change. Okay, so I told you already, it happened started during the incubation period. And then there's another activation in the peripheral. So then you know where your pathophysiology is. All right? Okay.
Okay. All right. Thank you, Lucy. There's the last presentation by Dr. Sharifah, and she's going to talk about patients with shock syndrome. Isn't sure, Diane?
Okay. All right. So well done to those who are still here. So try to get through one or two cases, depending on the time. So this patient is a 40-year-old gentleman who went to the clinic on day 2 of illness. He complained of fever, body ache, headache, poor appetite, and lethargic. And he denied, so he did not have any URTI symptoms, no rash, no bleeding, no abdominal pain, no vomiting. When the doctor examined him, his BP was 110/90, pulse rate 108, temperature 38.3, and the throat was injected. So when you look back at the history, there's a lot more that you probably should be asking. For example, how was the fever? How frequently did he need Panadol? You always think about dengue when somebody comes with an acute febrile illness, so thinking about whether there are any similar cases within the area or anyone in the family also has either febrile illnesses that has been diagnosed. Don't forget about when you ask about oral intake, the 3 golden question: how much oral fluid intake was taken, how much urine output, and what activity can the patient do. This golden question is not specifically for dengue. I mean, as you can see, it's a very general thing that we're teaching you here. You definitely need to ask it for any dengue patient, but when you have an acute febrile illness, these are all tips that will be useful for you, regardless of whether it's dengue or not. And then looking at the CCTVR and also the hydration status. So what happened instead for the patient was, after that brief history, he had a full blood count done, and this was his full blood count. You can see hematocrit 39, white cell was 7.2, platelet 235. This is day 2 of illness. So he was diagnosed with upper respiratory tract infection. Now remember, the patient did not complain of any respiratory symptoms. He did not complain of sore throat. He did not complain at all. But the doctors looked at the throat and said, oh, it's injected. Okay? So gave Panadol, gave cefuroxime, and also thymol gargle. So this was on day 2. Okay, also on day 3, he actually came back to the clinic at 10 a.m. He did not have any more fever, but he was vomiting frequently. He was more lethargic, temperature 36.5. So at that point, the doctor decided to do a full blood count and send for dengue serology. However, this particular clinic did not have a point of care test, so the serology will only come back the next day. But the full blood count came back. Hematocrit is now 48, white cell 3.1, and platelet of 74. Despite this, he was sent home and asked to come back the next day. Just so that you know, this is a foreigner. So I know the difficulties that you have with convincing foreigners to do bloods, to go to the hospital and so on. But this is what I know a lot of you are facing. But again, so what's missing? So I'm sure, what's missing here from this? From the history, from the, what would you like to know before deciding to send him home? Or at least have that documentation before deciding to send him home. Vital signs. There's nothing on the vital signs. And this is a true case. Memang tak ada. There was no BP, there was no pulse rate, there was no temperature. And the white cell is telling you that the patient has progressed quite dramatically, right? Raised hematocrit with a big drop in the platelet. So, despite this, basically, it sounded to us like the GP was waiting for the serology to come back before deciding what to do. I'm sure after a whole day being here, I'm sure you guys will treat him differently, right? So in this particular patient, the temperature had got down, so it means that he could be already in the critical phase. We don't know whether he has capillary permeability or not, but looking at the hematocrit, most likely. And as you can see, the white cell has also gone down together with the platelet. So he's in the critical phase now. So when they're in the critical phase, he's been vomiting away, he's very lethargic. That means he has warning signs. That means he needs to be referred without your dengue serology. So just a reminder of, assessing the patient, classifying them, and putting them into group A, group B, group C. So you do that, you'll know what to do next. So at this point of time, this is a probable dengue because results are pending, but looking at the full blood count, it looks very much like dengue. Day 3 of illness, at least 5 hours in critical phase, and he has warning signs. So he came back the next day. He was very weak at this point and very dehydrated. GP traced the combo test and it's positive for everything, NS1, IgM, IgG. He was immediately referred to the nearest hospital, which happened to be next door. Again, what do you think you should have done before? Vital signs lah dulu, right? He didn't even do the vital signs. We kept asking why, because ED is just next door. It doesn't matter lah, ED next door ke tak next door ke. You should do the vital signs. And also, I think this is a opportunity that if you had done the vital signs, maybe they would have picked up what his BP is. They could stratify him better, whether he was just warning sign, whether he had shock, and so on, and start the IV drip if needed. Okay, so in our opinion, it looks like patients in this particular practice, when it comes to dengue, the referral is based on the NS1 result. We shouldn't be doing that. Referral should be based on the classification of patient, either they are in group B or group C. Okay, so warning signs, severe dengue warrants immediate referral to the hospital. Okay, so he went to ED, and true enough, his CRT was very prolonged, coolish peripheries, no jaundice. So this one also they can do, they can hold the hand and whatnot. Pulse was 126 per minute, very weak and thready. BP was 100/90, respiratory rate was about 26 to 30. So it's very tachypneic. You can tell that he's very acidotic already. Abdomen, tender epigastrium around the right hypochondrial area. No rebound tenderness. ED put that to rule out severe dengue in compensated shock. These are slides from my trainee. And why do you think he put that emoticon there? There's no more to rule out, okay? And that's one positive, number one. So this is confirmed dengue. Even if the to rule out compensate, this is like nothing to rule out already. This is confirmed dengue. This is confirmed shock and confirmed compensated shock. Okay. Yeah, we need to stop doing this to rule out lah. So confirmed dengue in compensated shock on day 4 of illness. At least 29 hours in critical phase, because the point of effervescence was the day before. And again, when you're already in severe dengue, you don't need to bother already about warning sign ni. Okay? Okay lah, some people still nak tulis, tak apa, it's okay. But, focus, where are you now? You're now in severe dengue, you're now in shock. Okay? So, your plan of management is just one, fluid resuscitation first. Okay, so some of the pitfalls from this particular case. So full blood count can be normal in the early febrile phase of illness. So remember the platelet was 200 plus. Combo test is point of care test and is best done in the first 3 days of illness. So I do want to encourage every single GP to have a combo test in their clinic, especially if you're in the Klang Valley. I think you must have it, okay? Distraction by convenient diagnosis distract us to do the right thing. Again, somebody comes in with fever. Your gut tells you it's dengue. Yeah, a lot of GPs, they think it's dengue. Tapi I don't know, maybe the combo test is too expensive ataupun we had someone who had a past experience where they did it was negative and they kena marah by the patient. The patient went to the next clinic the next day, it was positive, and he said, well, are you bad GP, So we know all this. We've heard all this, but I think it's your how you explain. You know a bit more. Hopefully, you can explain a little bit better. Okay. Examine the patient, assess the CCTVR, vital signs trend, so doing a vital signs is very important. The GP that near my house, before we go in, we all have to do BP, pulse rate, temperature. So yeah, why not, right? Diagnose dengue and severity clinically first, then test for dengue early. So the diagnosis was not missed because the test was Okay, I think I've got 5 minutes. So remember this case? We talked about it. I just wanted to dig a little bit more, just to tease out a few more learning points from this particular case. So we talked about, the GP calling for the ambulance at 3 p.m. on the 12th of July. And we talked about starting a IV drip for this patient while waiting for the ambulance because he was showing signs of shock, or at least warning signs. Okay. So do you think that the ambulance should be called earlier? I think we sort of established this, that it could have been called even at 12 noon instead of waiting for the NS1 and full blood count to come back. Because at the end of the day, how do you define severe dengue, right? You don't define it by the NS1 positive. You define it by your clinical assessment. So again, just to reiterate that when he was seen at 12 noon, the BP was already low for him because you had a comparison BP, 100/60. We don't know what the pulse rate is. We don't know what the CCTVR is. And looking at the full blood count itself, somebody who has a platelet of 11,000 tells you that he's way into the critical phase, number one. And a HP of 18 means that his hematocrit kali 3 is like almost 60, right? So that's a very high hematocrit, okay? So again, suggesting that he's hemoconcentrating, if you couple that with your vital signs, it will tell you that this patient may have severe dengue and therefore more urgent name must be taken. Okay, so yes, it could have been done much earlier at 12 noon. And looking back, because this is the same GP that saw him at the second visit, what else do you think the GP could have done at the very first visit, which is day 2 of illness? What else can they do? A dengue combo test. Okay? So if the GP had done a dengue combo test and it turned out to be positive, then that would have stopped him from giving the Voltaren. No need to give the antibiotics, which can those things can cause problems as well. Okay. Again, even if the dengue combo test is negative, if the clinical suspicion is dengue, we shouldn't be giving Voltaren, NSAIDs, or antibiotics. But having that positive test will give you more oomph to tell the patient, I'm not going to give you this. Okay. Okay. So what if you can't put in an IV line? Because you know the history. This patient, by the time he was in hospital, was so difficult to get his line. What else can you do? You can actually try to give him orally. Yeah, then campur ORS, whatever. Ask him to take small sips just to get himself, instead of just waiting in the room, the waiting room, waiting for the ambulance to come because you can't put in the IV line in. So just try to give orally as best as you can. Okay. So what would have pushed the GP to call the ambulance much earlier? Again, I think if he had done the NS1 on day 2 and it's positive, and so when the patient came at 12 noon, he didn't have to worry anymore about the NS1, right? So you see the patient on day 4 noon, clinically looks like they have at least warning signs, most likely in shock as well because of the BP. That would have triggered him to immediately call the ambulance without having to wait for the bloods. And again, you can use it to convince the patient even more. This is serious. You have to come back. Okay. One GP asked me how to tell patient not to give Voltaren. Dia sakit badan semua. So we said we got pictures of Melina and fresh PR bleed. If you want, we can give it to you so that you can show the patient every time. Those who insist to have some NSAIDs. Okay. How would management be different? So again, if you knew NS1 was positive earlier, you would avoid using NSAIDs. You would educate him better to emphasize on how important it is to come back earlier, to come back daily, and you would have referred him much earlier at noon on day 4. So what would have made so you all are here now, right? So you're all in the best condition to do your full blood count ASAP, because you guys are the one who sees the patients first. And we've got data to show that patients actually, a majority of them do visit a doctor in the first 3 days. So the opportunity is with you all to do that early diagnostics, evaluation, and give the proper advice. Okay, yep. Yep. Ah. Oh, this is something, yeah, this is not cerita lama ni. So they don't have a combo test. Hantar outsource, yeah. So that's why I'm saying I think everyone should have a combo test. So going back to the same question, why do you think, no, the GP knew that the patient was unwell at noon kan, tapi bila sampai kat triage, pergi triage to the green area. Why? Because the GP has seen the patient. This is the second time the GP has seen the patient, and he can compare, right? The personnel who saw in ED, first time seeing, as we said lah, macho guy walking in, tak nak pergi hospital, right? He's trying to put up a better condition than what he actually is. Okay, all right, thank you.
Thank you very much. Thank you very much, Shafra. There's a question here. Sometimes it is difficult to be certain about the critical phase if based on afebrile timing due to paracetamol consumption and inconsistent history. Can we confirm the phase by serial FBC parameters and warning signs?
Yeah. Can again, it's all a combination, kan? But the thing that you can look at in terms of, so after they've passed the 72 hours and you have a serial full blood count, once the full blood count, the platelet drops below 100, you start to look very hard and see whether the patient has entered critical phase or not, right? It's a phase. It doesn't mean that everyone's going to go in plasma leak and go into shock and go into warning signs. No. Okay, if you remember that natural history, the percentage that are asymptomatic and then who go into severe dengue and then go into, and who are going to die is actually quite small. Okay. In fact, I think one of the latest guidelines from WHO, they've actually done another chart which says dengue fever recovery and then dengue fever critical phase recovery to illustrate that not everyone will really go into critical phase, meaning that they will have the warning signs and whatnot.
Another one, the last one. If the patient has vomiting 4 to 5 times and diarrhea 4 to 5 times a day, or 2 or 3 of illness, wouldn't it be appropriate to call it as a warning sign as you expect the patient to go into critical hemoconcentration right after that?
Yeah, so the reason why we say 72 hours is because your plasma, the significant plasma leakage often only happens after 72 hours. So the viremia, the vomiting that you're seeing that first 2-3 days is most likely secondary to the viremia. Okay, and it doesn't mean to say that therefore they will go into hemoconcentration, they will have plasma leakage. They may, right? So that's why we don't want to call it warning signs, because the moment you call it warning signs, then your fluid becomes like 5 cc per kg, then you overload the patient and whatnot. Okay, that's the only reason. It's a technical. In a way, it's a technicality, but at the same time, it also your management is different. So I still feel, in that 2 to 3 days, if they're having symptoms that look like warning signs because they're having vomiting, they are lethargic and whatnot, but it's not warning signs in the true sense. That is plasma leakage, that you need to admit them, you need to give them 5 cc and all that, okay? But it doesn't say that you don't need to admit them. If they really can't take orally, they still need hydration, then by all means call your doctors, call your primary care or ED and refer them appropriately.
Okay, thank you very much. The question about the ibuprofen for children is the same, right? Same rule applies. All right, thank you very much, Dr. Sharifa. Okay, so we
also add to the ibuprofen story. This is, I knew a lot of parents, sometimes they GPs are under a lot of pressure because the parents say, I want something to make the fever come down quickly. I'm so scared of, blah, 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 febrile illness, febrile seizures and all that. I think as a doctor, we shouldn't be undergo this kind of pressure. We have to educate the parents, If I give you ibuprofen, the possible danger is not now, but 3 days. The temperature is a very strong, potent antipyrectic. But I always tell them, the more potent the antipyrectic, the more potent the side effects. And tell them what the side effects are. Is bleeding. It's severe bleeding. It's not like the ordinary melena. It's really going to be fresh blood rushing out from the rectum. So let them know that, and then they will suddenly say, oh, this one is a poison, racun already. From a medicine into a racun, you can quickly change their mind.
All right, thank you very much. Now, I must admit that when we planned this, my intention was actually just two. One is to let people know that the vaccine is available. And the second was to make sure that doctors treat the patients well, make the diagnosis, recognize the symptoms early, diagnose early, and then refer appropriately or use the fluids judiciously. Those were just the two intentions I had, and I wanted to become advocates for vaccination. And it was, I have to admit, it's difficult to actually organize something where you have the clinical component with the vaccines. And I want to actually thank Takeda for supporting this and agreeing that this is of benefit. And we're trying to do a few more of these so that more of this information gets to people in the rest of the country, right? Now there's a feedback form, so for if you don't mind, just screenshot and then give us the feedback. And then a gentle reminder about your in-clinic educational materials and the Immunize for Life Professional Network if you want to register your clinics. And I understand that there are now 644 online participants. That's quite good for a Sunday. So thank you very much and I hope that you've gained something from all of this. It's been very fruitful, and have a good the rest of the weekend that's left of it, and try and enjoy and watch Spain win tonight. Thank you very much.